Hello to all my dear students. Let's start with the chapter Lens. Okay, so all of you give the heading Diseases of Lens. Okay, talking about first thing is, what is the shape of the lens? Let us draw it. Shape of the lens, biconvex. Diameter, this is an exam question, okay? We put a Q here. Then diameter, we all know it is 9 to 10 millimeter. Less than 9 is what is called microphakia. Less than 9 is microphakia. Micro means small and phakia means lens. Okay? Okay, so when we are talking about diameter, we are talking about this equatorial diameter. Okay, what is equator of the lens? Okay, look up all of you. If this is the anterior surface, right, and this is the posterior surface, the plane where it is meeting, this plane is called the equator of the lens. We'll see the slide shortly. So that plane is called equator of the lens. Right, so in this diagram, this becomes the equator. And what is the power of the lens? We all have learnt in introduction also. Power of lens is how much? It is 16 to 17 diopters. Power of lens 16 to 17 diopters. Then next is, what is the refractive index of the lens? Index, these are all important cues, okay? Index is 1.39 you should learn, sorry. Learn first as 1.39. Next question is, where is the index maximum? So common sense, index is going to be maximum where the part of the lens is hardest, right? So that is the center. We all know that nucleus is, the center part is the hardest. So the refractive index, your answer is maximum at the center of lens. And what is the value here? Now you will write as 1.4 to 1.41. Okay? Okay. So now we talk about structure. Next heading, structure of the lens. So we know about the shape of the lens, its power, its refractive index, what is the diameter normal, what is microphakia. Okay, you're learning with me now. I told you have to learn along with me, and don't forget to make all the Qs and double Qs on your copy. Again, I'm repeating, Q is your exam question for your PG entrance and double Q is a repeated question. Correct? Okay. Then we talk about structure. So all of you draw this. So this is a biconvex structure covered with a capsule, and this capsule is very, very elastic. This capsule is very, very elastic. Now, interesting part, it is very elastic. This is the capsule, but it has no elastic tissue. Note down, please. Capsule has no elastic tissue. It is mainly type 4 collagen. We can also learn an interesting fact here. It is the thickest basement membrane of your body. Okay, it is the thickest basement membrane of the body. So if this is the anterior part, if this is a cornea and this becomes your anterior part, this adult lens has got a single layer of anterior epithelial cells. And what is the role of these cells? Let's see. These single layer of anterior epithelial cells. First write down here. What about the posterior layer? This is permanently transformed into lens fibers during embryonic development. And these lens fibers, which are directly coming from the posterior epithelial layer, are called primary lens fibers. Right? So, what are primary lens fibers? Where the posterior epithelial layer has transformed into lens fibers. Another interesting thing is that these anterior epithelial cells, we can divide as, these are A cells, okay? Now A cells and the towards the equator, these are called E cells, equatorial cells or E cells. And it is these E cells which give rise to the lens fibers, which are forming the lens fibers. The central part of the lens is the nucleus, and the peripheral part is called the cortex. Cortex is an area where it is loosely arranged, but all the fresh fibers are superimposed on the cortex. And the central part is the nucleus. Now, this nucleus, let's make it here, make the another diagram, all of you with me. Nucleus can be divided as, depending on what time period it is formed, it can be embryonic, then fetal. So when you say embryonic, it is from 0 to 3 months of gestation. Fetal, this becomes 3 months to 8 months. Then infantile, and infantile is from more than 8 months to puberty. Okay, this is infantile. And when you say adult nucleus, we are meaning after puberty. Right? So, these are the parts of the nucleus. Now, coming back to this story that when these lens fibers are formed, so there is a small gap, that is a microscopic gap is left behind. So, if this is the fiber from this side and this is the fiber from this side. So, we are seeing some microscopic gaps. Let's have a look. If you see in this slide, this is what I'm trying to tell you. This is the equator, this is the antiepithelial layer, right? And what we are saying, this microscopic gap, can you see this? This zigzag line, these are what are called sutures. So the lens fibers are formed from here also, and the gap is what is called sutures. Now you can draw it on your diagram that this suture, when I see from anterior surface, looks like a straight Y. And when I'm seeing the lens posteriorly, it looks like inverted Y. What are we saying? These are what? These are sutures, correct? They are microscopic gaps. So whatever you have, let's see a few more slides first. So these are the different parts of the nucleus as we just learned: embryonic, fetal, infantile and adult. Let us look at this slide. This will make things absolutely clear to you what is equator of the lens. So if this is the anterior surface and this is the posterior surface, the plane where it is meeting is called the equator of the lens. Correct? So if you are drawing the lens like this, where is the equator? This becomes the equator of the lens, right? Okay. So the ideal method of examining the lens is through the slit lamp. And when we are seeing through the slit lamp, what do we see? We should know that if this is the corneal section, right? And this becomes your section of the lens when I see through the slit lamp. Let's get back to our notes. Okay. So on this diagram, another important thing, we have already marked equator. If not, let's mark it. So this becomes the equator of the lens. And what are poles? Center point anteriorly is anterior pole and center point posteriorly is posterior pole. Okay. So this becomes anterior pole and this becomes your posterior pole. So very quickly again for you all, lens is biconvex, covered with a capsule which is very, very elastic, right? Though it has no elastic tissue. Okay? It has got a single layer of antiepithelial cells, which it is the E cells which will form the lens fibers, right? The plane where the two surfaces are meeting is called equator. Center point anteriorly is anterior pole, posteriorly posterior pole. The central part is the nucleus and peripheral is the cortex. I think absolutely clear about what is the structure of the lens. Now let us talk about what are the questions asked in your exams. So the first question that they can ask you is, lens is thinnest at. So which is the thinnest part of the lens? It is the capsule at posterior pole. Please note down all of you. Make a Q and write down thinnest is capsule at posterior pole. So this capsule at posterior pole, what is just to make things clear, capsule at posterior pole is the thinnest part, please note it down, and the thickness here is only 4 microns. And the thickest part is pre-equatorial. Thickest क्या होगा? We'll answer it is pre-equatorial. Part is the thickest part. But the question has been asked for the thinnest. Second question they have asked you, which are the youngest fibers? Of course, cortex, isn't it? So write down. Let's write it separately. Youngest fibers, we will answer cortex. Next question. Till what time period are the lens fibers formed? So, which age? Till what age the lens fibers are formed? We will say it is throughout life. So, write down. Lens fibers are formed throughout life. Important questions, okay? So, we will keep this in mind. That was about the structure in anatomy. What next we have to know is, what is the physiology? So, our next heading will be physiology. First point that we discussed in introduction also, lens is avascular. Okay? It has to be because it needs to be transparent and therefore it is avascular. Tell me one more thing related to anatomy which needs a mention before I further proceed to the physiology part. We know that where is this lens exactly situated? Just, okay, I'll write it here. Note it down. What needs a mention here is, what will you say? This is the diagram. Make the diagram, all of you. Where is the lens situated? You will answer in the posterior chamber. Where in the posterior chamber? Patellar fossa. Okay. So this space which is formed by this dotted line is nothing but condensed part of the vitreous, which is called anterior hyaloid membrane. Can you just add this in the anatomy part, please? So anterior hyaloid membrane. Okay. So this whole thing is called patellar fossa, right? The space between the two is called Berger's space. This is called Berger's space. So just remember that lens is situated in the patellar fossa in the posterior chamber. If some part of the lens is still in the patellar fossa, the rest is not, this is what is partial dislocation. We call it subluxation of lens. When it is partially dislocated, some part is still in the patellar fossa, some is not. That is what is called subluxation. We'll talk about subluxation in detail later on. Okay, so if you have added that, we come back to physiology. We said that it is avascular structure, correct. Secondly, what about dehydrated? Needs mention. So please understand something here. Though if you look at the component of the lens, 66% is water. Why am I calling it dehydrated? Because even a little hydration leads to cataract. Therefore, we consider the lens to be dehydrated structure. Okay? So, we'll consider it as dehydrated because I'm repeating, even a little hydration leads to cataract. Third thing is exam question again here for you all. Please make a cue there, which is the primary metabolism. So, metabolism, if I'm asking you primary, common sense, both are present. I am asking you which is primary. So, primary metabolism, we will answer is anaerobic. So, this is not enough. They have asked you how much percent of glucose is metabolized anaerobically. It is 80% or more glucose in the lens is metabolized anaerobically. Please remember this. Correct? Okay. Another important thing that we have to know in physiology is what is pump leak theory. Okay, so we talked about dehydration and I said it is dehydrated. We consider it dehydrated and dehydration can cause cataract. Now, if it is maintaining its dehydrated state and not allowing any hydration, there has to be some mechanism. So, we will just have an idea what is pump leak theory. Now, I am simplifying it and explaining it to you. Everybody knows that water is always more where there is sodium. Wherever the sodium will go, water will be imbibed there. Correct? What is pump leak theory? Please draw the diagram. This is your lens. This is the anterior segment. Now, what is happening at the anterior surface is a pump mechanism where sodium is pumped inside or outside. Inside or outside? All of you? The sodium is pumped outside. I don't want water inside. And potassium is pumped inside. Okay, so this pump mechanism is happening on the anterior surface where sodium is pumped in the aqueous and potassium goes inside, so that the water is all coming out of the lens. This is the sodium potassium ATPase pump working here in the anterior surface. Okay, so this is the anterior surface. Draw it. And what is happening at the posterior part? At the posterior surface, there is a leak. This was a pump, now there is a leak. What leak? Now in the leak phenomenon, it is the sodium which is leaking in and the potassium that is leaking out. Okay, if you are going to have a look at this diagram, you will see it's quite complicated, but we have to only understand this much. Right? This is the main important part. We don't have to talk about other salts. Sodium, potassium should be just understood properly. Right? Okay. So this is your pump leak theory, which explains how your lens is maintaining its dehydrated state. Right. So one question is on primary metabolism. Let's not forget this one. The next important thing that you have to also understand is about lens proteins. So let us learn a little bit more about lens proteins in detail. Let's talk in detail. Lens proteins, please learn along. It's very simple. Soluble or insoluble, right? So we are talking about water soluble or water insoluble. Okay, so when you say water soluble, they are mainly crystallines. Okay, they are mainly crystallines. And crystallines can be alpha, beta, gamma. Alpha, beta, gamma. Okay, easy to learn? Now, another thing that you have to know is high molecular weight proteins, mainly 1 and 2 are also soluble proteins in the lens. Coming to insoluble may, okay, so 1 is, you further divide it as, you may not learn this division or you may, it's up to you, urea soluble and insoluble. If I say urea soluble, these are cytoskeletal proteins. So there's a list of cytoskeletal proteins. We don't need to know it. In so many years of my teaching, I haven't seen any single question. But yes, know this, that this is mainly present in the protein, in the lens, and it is insoluble protein. One name if you want to know is vimentin. And when you say insoluble, we will learn again one name only, and that is MIP. MIP stands for major intrinsic protein. Major intrinsic protein. Okay? Another insoluble apart from that is a high molecular weight, 3 and 4. This has been your exam question, guys. Let's note it down, make a cue, that this high molecular weight 3 and 4 is responsible for cataract formation. And further here, it is the high molecular weight 4 which is actually responsible for nuclear cataract. This is responsible for nuclear cataract. Done? Okay. So that was about your physiology. Let's talk about pathology now. So our next heading would be cataract. Everybody knows what is cataract? Yes, so it is opacity in the lens, isn't it? So common sense, if I talk in a simple language, we know that the light rays should not be interrupted at any level while it is being focused on the retina, correct? Therefore, it is so important for both cornea and lens to be absolutely transparent, and this is the reason both cornea and lens are avascular. Now, if there are any opacities, it interrupts with the light rays and therefore it affects the vision and visual acuity decreases. This opacity in the lens is called cataract. Understood? Okay, if you have understood, let's write it formally also. So, we'll define cataract as any opacity in the lens which hinders its optical homogeneity, which hinders its optical homogeneity. Okay, so any opacity which hinders its optical homogeneity is cataract. Now, classification. Next heading is classification. You can divide this cataract as congenital or acquired, right? Congenital or acquired. Now, further congenital cataract, we can further divide as either infantile. When you say infantile, it is within 1 year of age. Okay, so this is less than 1 year of age. So what do we mean here? If it is less than 1 year, we are talking about embryonic and fetal nucleus, right? So we are talking here about this part of the lens, embryonic and fetal nucleus. And when you say developmental, this is all type of congenital cataract which is more than 1 year is developmental. We'll take this later. Next we come to acquired. Let's first finish the classification. So again, developmental will be infantile and adult. We all know that. Okay. So we next talk about is acquired cataract. How do you classify acquired cataract? There are 3 ways of classifying acquired cataract. Okay, we'll learn like this, that there are 3 different ways of classifying it. One is, I can classify it as anatomical classification. Or second, it can be classified according to maturity. Okay, according to maturity. And third, etiological classification. Etiological classification. Okay. So, one by one, our first heading is anatomical. Now you will learn with me common sense. So we'll make a diagram here. Very, very simple to understand this. We already know about the anatomy, isn't it? I meant common sense here, that we already know about the anatomy. So do you realize that if the whole lens is involved in opacity, we are not able to distinguish anything. But from where it started, the early changes, according to that, I can classify anatomically. Okay? Now, anatomically, when you divide it, you already know the parts. Let's make a diagram and label it. Please draw. Diagrams are very, very important. Don't run away from diagrams at all. Okay? So, because you see, I have explained you earlier also in my lectures that picture memory plays a major role in your retention of things. Okay? So, keep making diagrams and labeling it, putting cues there. That's what I do. Okay, so once you have made this, now we all know about the parts of the lenses. If this becomes the anterior part, correct, and this is the capsule, we already know the cortex and the nucleus. This much I want you to draw. So according to from where it started, we can classify cataract as anterior subcapsular. Easy. Then it can be anterior cortical. It can be nuclear. It can be posterior cortical or posterior subcapsular. Posterior subcapsular. Okay? And then, of course, don't forget anterior polar and posterior polar. So these can be the anatomically classified types of cataract. Now what is the question asked? Time for a question here. Make a cue. They ask you among all which will diminish the vision most. Okay. So we will write this cue for ourselves. Write down which lenticular opacity diminishes the vision most. So which lenticular opacity diminishes the vision most? And what will be your answer? PSC, posterior subcapsular cataract, causes maximum diminution of vision. Maximum diminution of vision. Why? Next question is why? This is because it is near the nodal point of eye. I've talked about nodal point in my introduction chapter. Please go through it. Near the nodal point of the eye, which is the first focal point situated just behind the lens. Okay? So, this is the reason PSC will diminish the vision most. Okay. This was your anatomical classification. We next talk about is according to maturity. Next heading is according to maturity. So very simple, everybody knows this. According to maturity, we can divide it as immature cataract. What does it mean? Some part of the lens is opaque, some part is clear. This is immature. Then mature cataract, where whole lens is opaque. And then comes your hypermature cataract. Right? And hypermature can either be Morganian or it could be, so one name we have to be familiar with is Morganian, or it can be sclerotic. Right? So, this is sclerotic means shrunk. Okay, so everything is shrunk capsule, wrinkled anterior capsule, it becomes, happens in sclerotic. What happens in Morganian? Again, there is a wrinkled capsule, but along with that, Morganian, the major part is that the cortex liquefies. This is very, very typical. I think we all remember this. We have learned in our MBBS. Ki the cortex liquefies and the cataractus nucleus is just dancing when the patient is turning his head right or left. So what happens? The nucleus is dancing in the liquefied cortex. So that is what is Morganian. If you want to draw it, we'll draw something like this. It's a hypermature stage. Draw this. We will say there is wrinkling of capsule, which you have seen in both types. But especially in Morganian, what is happening is liquefaction of cortex. We'll see all the slides. First let's note down. So, liquefaction of cortex. Okay? So, that was about your talking about according to maturity. There's another question that needs a mention here. This is regarding immature cataract. They have asked you, where do you get the iris shadow? They don't ask you now, and I don't expect a question from this at all. But it's a very curious question from all the students. Ma'am, what is iris shadow? How do you see that? So, it is the shadow of the iris on the lens. Okay. So, think yourself if this is your iris. Let's draw it together. It has to be immature cataract only because, see, if this is the lens, right? And this part, suppose, is opaque. Some part is opaque. And some part, okay. So, what happens? This part is clear, the black part. And suppose this is the cataractus change and this part is opaque. Right? So, when there is a clear area, the shadow of iris will fall on the lens. And this on the lens is what is called iris shadow. Shadow of iris on the lens. Did you understand this? Okay, think yourself. What will happen when you're standing in front of the wall and you see your shadow, right, at night? So, do you realize that when you're very close to the wall, you can't see? There has to be a distance from the wall, no? So, we have to revise our physics here. Same is true. Just imagine, if it is a mature cataract, what is happening? If it is a mature cataract, this is the iris and there is no gap in the lens here. It is all opaque. When it is all opaque, there will be no iris shadow. So, no iris shadow out here. Okay? So, iris shadow will be seen only in immature cataract where there is a clear space for the shadow to be formed and seen. Correct? Take care. Then we talk about, so this was about your immature, mature and hypermature. That is how you classify according to the maturity. What was the third way of classifying? Third way of classifying is etiologically. Before that, since I've been describing about Morganian, let's have a look at Morganian. Okay, let's see this slide. What do you see? This is the liquefied cortex and this is the nuclear or harder part inside this liquefied cortex. So you're looking at Morgagnonian cataract. We'll see it again when we talk about senile cataract. Just have a look at this one. Right? So when the patient is turning his head, this will be dancing inside the liquefied cortex. Now next give the heading etiological classification. Etiologically, we can classify cataract as, we all know that, etiologically we can classify it as senile, metabolic, complicated. Complicated is also called secondary. Toxic cataract, traumatic, and we write it here, radiational, and also associated with seismic disease, which we call pre-senile cataract. One is senile, and when it is less than 50 years of age, we call it pre-senile cataract. Okay, so associated with seismic disease. Now we are going to take one by one. So first, which is the most common among all? We all know most. This is your exam question. Most common is senile. Right? Write down most common is senile. We all know this. So we start with senile. Give the heading, senile cataract can be of three types. Either we talk about cortical, when it starts from the cortex, nuclear, when it is starting from the nuclear, or it can be subcapsular. Right? So let's take one by one. First is cortical cataract. Cortical cataract, all of you, cortical cataract, what is the etiology? We first start thinking about the etiology. Hydration. I told you, any amount of hydration can lead to cataract. So etiology of the cortical is hydration of the lens. So we will write etiology is hydration of lens. So with the clinical feature is it is divided into different stages. So initially there will be little water, then little more and so on. Therefore the amount of opacities are increasing and the stage of cataract is increasing from mature and lastly hypermature. So common sense, whenever the water is actually accumulated, it will first accumulate as clefts and vacuoles inside, right? So this is what is happening as stage 1. First the clefts and vacuoles, these are seen between the lens fibers. Even if we don't mention, it's okay, it's common sense. After this, when there are clefts and vacuoles of water filled with water inside between the lens fibers, what is happening? There is a stage of lamellar separation. So this is stage 1. We are coming to stage of lamellar separation. Next, what happens? Little more hydration and cataractous changes will lead to second stage is incipient cataract. Incipient cataract means, again, it's an immature cataract where you can see spoke-like opacities. Please make all the diagrams what I'm making. So this spoke-like opacities, this is what is also called cuneiform cataract. Let's have a look. So see, this is the incipient stage, means these are the spoke-like opacities I'm talking about, right? So here also it's so very clear. This is cuneiform cataract. Okay, after this incipient cataract or incipient stage, what is the next stage after incipient stage? Stage 3 will be, before I go to the formal stage 3, think yourself, everything is due to hydration. So think yourself, everything is due to hydration of the lens, correct? So more water, it will lead to incipient. Now there will be maximum water, which is called intumescent cataract. So you all should know this. Incipient later will become intumescent cataract, where there is maximum hydration of lens, right? And then comes the next stage, that is immature cataract, right? So this is all further cataractous changes have occurred due to all this hydration, leading to immature cataract. And later there will be stage 4, which is mature cataract, which means now whole lens is opaque. And lastly comes your hypermature stage, stage 5. This hypermature, I have already mentioned you, can be Morgagnonian, right? Or it could be sclerotic. Okay? So this is about your stages of cortical cataract. Okay, one very important exam question. We put a Q here. What is the most common complication of hypermature Morgagnonian cataract? Most common, make a Q and write down, most common complication of hypermature Morgagnonian. So what are you going to write? So our answer would be, for this, our answer is phacolytic glaucoma. Phaco means lens and lytic is lysis. I told you now there is wrinkling of capsule and liquefaction of cortex. So lytic, lysis is lytic hona chahiye. This is write down phacolytic glaucoma is your answer. It's a double Q actually. Repeated question. So when you say phacolytic glaucoma is the most common complication of Morgagnonian, what is it? So what is the story? Let's see. It's very interesting. So what is happening here? Due to the hypermature stage, right? Lens protein, and because of the wrinkling of the capsule, the lens protein leaks out into the aqueous humor. Correct? Now, once the lens protein is leaking out, it is going to flow with the aqueous. We have already understood all of this in your introduction chapter also, that it can block the trabecular meshwork, and this will lead to glaucoma, which is generally open angle. Any blockage of TM is open angle glaucoma. OAG is open angle glaucoma. I think I mentioned this. When do you say the angle closed? When there is no space left. The space is all obliterated between iris and cornea. Anyway, so this is the reason of phacolytic. So what if you want to write it? Make the diagram and write down. It is leakage of lens protein blocking the TM. Leakage of lens protein blocking the trabecular meshwork. Leakage of lens protein blocking the trabecular meshwork. Right? Okay, so once we know this, let's also understand some other words. First was phacolytic. Another term is phacotoxic. What is phacotoxic glaucoma? Very easy. This is also called lens particle glaucoma. Write down. Lens particle glaucoma. T for T. Toxic trauma. Easy. So any trauma, the story becomes same now. Etiology is only different. This time it's not Morgagnonian. It is trauma. Trauma is going to lead to capsule rupture. And any capsule rupture will again cause the lens protein into the aqueous. Any lens protein in aqueous will finally block the trabecular meshwork, leading to open angle glaucoma. Simple. So this one is what? It is phacotoxic glaucoma. Right? Next, which is the next one? What do we mean by phacoanaphylactic glaucoma? Now, when you say phacoanaphylactic, we all have to understand a very important fact here, that lens protein is not exposed to our immune system. Whenever the lens protein is out of the capsule, it is going to incite immune reaction. So the macrophages are all aggregated around the protein. This will happen. Okay, listen, then we will write together. So macrophages which are aggregating engulf the protein and they block the TM. This is phacoanaphylactic. So let us write down what is happening is immune reaction towards the lens antigen, towards the lens protein. When there is immune reaction towards the lens protein, because it's like a foreign body to the eye, or it's like a foreign body to the body itself, because it's not exposed to your immune system. So whenever these macrophages, write down, there will be release of macrophages. Next, write down release of macrophages. And this release of macrophages it will engulf the protein, and after engulfing the protein, it blocks the trabecular mesh. Engulfs the protein and blocks the trabecular mesh. Again, therefore, it is open angle. Right? Now, there is one more question here. We will put a Q first and learn this. What type of antigen is Lense protein? So, we have to understand which type of antigen. It is sequestered. It is sequestered in the capsule. So, when it is leaking out, it is causing a problem. So, it is a sequestered antigen. This is again exam question. It's a sequestered antigen. Okay? Done? Another term. What is? We learned phacolytic, phacotoxic, phacoanaphylactic. Now tell me what is phacomorphic. So morphology of the lens, due to morphology of the lens when there is glaucoma, we call it phacomorphic. What happens here? Intumescent cataract, you all know, means maximum hydration. When it swells so much that it starts blocking the pupil. So when the swelling of this lens blocks the pupil, aqueous cannot flow anteriorly, and therefore it is going to push this iris forward, and there will be blocking of the angle leading to glaucoma. So this time what is happening? Let us note down together. Intumescent cataract is causing pupillary block, and this intumescent cataract causing pupillary block, and this will finally lead to angle closure glaucoma. This is leading to ACG, stands for angle closure glaucoma. Okay. Is there any other term also? One more. Write down phacotopic glaucoma. What is this? Topic means this time it is due to dislocation or subluxation, or mainly dislocation of the lens. So, due to dislocation, sometimes subluxation, but mainly dislocation of lens. So, you can say it's dislocation oblique subluxation, but mainly dislocation of lens. So, if it is dislocated anteriorly and it is going into the anterior chamber, so this is the problem is in drainage through the TM, but if it is going posterior chamber, it will push the iris forward, and therefore leading to angle closure. You may not know this, it's not needed much, but just understand. So this lens, common sense, if it goes anteriorly, anterior dislocation will be leading to open angle glaucomas, right? But if it is a posterior dislocation, this is going to lead to angle closure glaucoma. Because now it is going to push the iris, and this is going to, when it is dislocated here, it is going to push the iris forward, right? So any dislocated lens posteriorly will be causing more of the angle closure. So if you don't want to learn this, it's absolutely fine. A liberty from me, you may avoid it, but just know about what is phacotopic. Anyway, don't have to learn, it's common sense. I've explained you how. Isn't it? Very easy. Okay, so that was about your cortical cataract. I think it was good and we have learned everything around it. We can move to nuclear cataract. Okay, so second type of senile is nuclear. When we say nuclear cataract, so nuclear cataract, all of you, what is the etiology? This time you will answer, this is nuclear sclerosis. Now, what is sclerosis? Is hardening. What exactly is happening in this process? Okay, so what is happening in this process of sclerosis? Let's understand. There is an oxidative injury to the lens. Okay. Now, because of this oxidative injury, that means you can say when the free radical scavenger system of the lens is not enough. Then what happens? It leads to denaturation of proteins. Okay. So, when there is denaturation of proteins and there will be increase in insoluble protein and decrease in the, so denaturation, okay, denaturation is causing, you write like this, decrease in soluble protein. Okay, So, denaturation. So, what is happening? Oxidative injury is causing denaturation of the proteins. Another cause can be dehydrational crisis. So, when there is severe dehydration, you must have seen, it is written in your books, they have asked you once where the severe dehydration was an option. So, severe dehydration crisis can also lead to, can be a cause of cataract because of the denaturation of proteins, decrease in the soluble protein. And, make a cue here. And also, so end result, what is happening? What is the gist? So, in this sclerosis, what is happening because of all this? There is decrease of soluble protein and increase in insoluble protein. Okay. Plus, another thing that is happening is also there is deposition of pigments. That is why you see that the nuclear cataract is seen colored. Deposition of pigments. Now, here comes your cue. Which pigments? We will learn urochrome and melanin. Important, please learn the two pigments that can be deposited is urochrome and melanin. So, because of this, there is nuclear cataract. And because of the deposition, now this nuclear cataract has different color grades. It can be either yellow, amber colored, right? More deposition, it can become brown, that is brunescence. And Nigra is black. Later it becomes black. These are the different color options. Black is called Nigra and brown is brunescence. Okay? Now, when there is a yellow colored nuclear cataract, so the vision can be yellow vision is what is called xanthopsia. Okay, so we can just have, this is interesting, we can learn. It is due to the urochrome deposition. The patient can have xanthopsia. What is xanthopsia? Yellow vision. Okay, even if you don't want to learn, it's okay. They have not asked you. At your level, we can spare you with this, from this. Okay? But you should know the etiology, what is happening, and you should know about the appearance of a nuclear cataract. So again, once you know the etiology and everything here, before we move further, we just said denaturation can be an oxidative injury, not enough free radical scavenger activity. So we have to know what are the free radical scavengers in the lens. Very important, I'll let you know where the question was asked. Give the heading. Free radical scavengers. So free radical scavenger in lens, we can mention as number 1, vitamin C. Okay, so Lense has got a separate carrier system, sodium dependent carrier system for vitamin C. Of course, vitamin E. Then we have to know about glutathione reductase, catalase, and superoxide dismutase. SOD is superoxide dismutase. Okay, just also remember anaerobic condition in the lens. That is also helping as avoiding any oxidative injury. Lastly is anaerobic conditions of lens. Correct, all of you? So, these are the free radical scavengers. Now, what was the question asked? Whether vitamin A is a part of free radical scavenger? It is not. So, make a cue, write down not vitamin A. We next talk about clinical features in nuclear cataract. We can again describe it as immature cataract. Very simple. Mature cataract and hypermature. And what is the name? This time becomes, this is mainly sclerotic, isn't it? It's all nuclear sclerosis. So, this is what is hypermature nuclear sclerotic cataract. So now they have asked you here. So this mainly is a sclerotic hypermature cataract. What is the most common complication of this condition? Now make a cue and note down. Most common complication we will answer is subluxation of lens. Okay, so we'll answer subluxation of lens. And which is the most common cause of subluxation? Another cue for you. Most common cause of subluxation, if they ask you, we have to answer trauma. Okay, then our answer is trauma. Right, guys? Okay, so now there is another question which is absolutely very, very important for you to understand. We will put a double Q first. And the question says, in which condition do you get second sight of old age? So, in inverted commas, second sight or second sight of old age. What is this and where do you get it? We have to understand this at present. Huh? Let's understand this. What is second sight of old age? Are you listening? Pay attention. It's very interesting. So when you say second sight of old age, first we have to understand the basics of accommodation. So, what are the components of near reflex? Matlab, I'm trying to ask you, what happens when you look from a far distance to a near distance? Three things are happening in your eye. What are those? One is your convergence, isn't it? Your eye will converge to look at the near. Then there is constriction of pupil, which we call meiosis. And the third process that is happening is your accommodation. Right? The third thing that is happening is accommodation. Okay, what is this? Let's understand. So, when you say accommodation, see, when I am looking at the far distance, I need lesser refractive power. And when I am looking at the near, I need more refractive power. Okay, and if you're looking at intermediate, accordingly your refractive power requirement is different. We are hardly aware of it. We can see far, we can see intermediate, we can see near without actually thinking about changing of refractive power. Okay, so but this is happening automatically in your eye and this is the process of accommodation. Did you understand why the term accommodation? According to where I am looking at, the refractive power of my eye is accommodating or adjusting or changing. That is why you call it accommodation. Correct? Got it? So, what are the steps of accommodation? So, I just told you now that from far, when you're looking from far to near, your power has to increase. How does this happen? Let's make a diagram. Okay. Make the diagram, this is ciliary body, the ciliary muscles, the lens and the suspensory ligament. Let's make this much only. The first step that is happening from when I am looking from far to near is contraction of ciliary muscles. Write down, contraction of ciliary muscles. Okay, so when the ciliary muscles contract, what will happen? So this diagram you are seeing in a section, but think yourself all around the ciliary muscle, attached to that are the suspensory ligaments. So when the ciliary muscle is contracting, these ligaments are going to relax. Okay, so what do we mean by this is this. If you look here, this is an unaccommodated lens. But what happens when there is contraction of ciliary muscles? When the ciliary muscles are contracting, these zonules are relaxing. So, and when this will relax, see this was the anterior surface in an unaccommodated state. Once the zonules relax, there is more curvature of the lens. Let's make it in a diagram. So, the first step is contraction of ciliary muscles, which causes relaxation of zonules, and this leads to slight increase in curvature of lens. This is called accommodation. And have we not learned this? More the curvature, more the refractive power. So whatever increase in the curvature of the lens will lead to increase in the refractive power. Okay? So this is 1, 2, 3. This is the process of accommodation. Contraction of ciliary muscle, relaxation of zonules and more curvature of the lens. Correct? So this is what is leading to your accommodation. So, if the unaccommodated lens, if the radius of curvature, if you think, in unaccommodated lens, it is 10 and 6. But when the curvature increases, naturally radius of curvature will decrease. So this is for accommodated lens. Got it, guys? So this was about your what is accommodation. So if we know what is accommodation, let's move further here. What happens after the age of 40 and above? At the age of 40 or above, this is a normal process, just like graying of hairs. So just like graying of hairs, what is happening when your age is more than 40 or more than 40? Some people 1 year before, some 1 or 2 years after, but this is around average figure. 2 age-related processes have already started. One is your weakening of ciliary muscles, and second is relaxation of zonule. Oh, I'm so sorry. And second is your less elasticity of the lens. Okay? So when the lens is less elastic, means there is rigidity. It won't change its shape so easily. This is what we mean. So less elasticity of the lens. Now because of these two age-related changes, now when I'm looking from far to near, I'm not able to focus. I'm better like this. So if I just remove this and I'm trying to look here, I'm not able to focus. I'm better like this than this. So this difficulty of near vision is not due to any refractive error. This is why it is happening, because of these changes, weakening of ciliary muscles, relax, and due to the less elasticity of the lens. So where is the error? Error is in accommodation. And this error of accommodation is what we call presbyopia. Okay? So please be very clear that presbyopia, I'm repeating, presbyopia is not error of refraction, it is error of accommodation. So this error of accommodation, not error of refraction. So this error of accommodation is what is called presbyopia. ठीक है? Okay, so करें क्या? How to solve this problem? You want more power for the near. Which lens gives you more power? Convex lens. So put a convex lens. So use a convex lens on the near glasses and you will see it clearly by increasing the power of your eye. Okay, I can do that, but then how is it different from hypermetropia? Hypermetropia also I am putting a convex lens. Yes, we are. But that we are using all throughout, far, near, every time. It is not for near. But only for near, this happens only in presbyopia. Okay? Therefore, we call them near glasses or presbyopic glasses. So, we are using near glass or presbyopic glasses, which are nothing but convex lenses. Correct? So, this is the treatment of presbyopia. Okay, so we now know everything about accommodation. Comes another point. What is second sight of old age? So, this second sight of old age is nothing but improvement in the near glasses which a patient finds himself in old age. Okay, let me explain it to you. I got a patient in my OPD. He's 65 years of age. I do his refraction. He is already using, this is an example, using a near glass of plus 2.5 diopter spherical. Now, when I see him and I do his refraction, I realize, no, now he needs only plus 2. He's very happy. So people in old age get so many diseases and look at me. My number is also improving. So this is second sight of old age, which is making him happy, but actually, should he really be happy for this? So this improvement of near glasses, write down, what is second sight of old age? Improvement in near glass. Now, once you know what is second sight of old age, now why is it happening? Is it really a point to be happy about? Definitely not. Go back to your diagram. What is happening is, this patient is developing early stages of nuclear cataract. There is nuclear sclerosis. So, what is happening? Suppose he has already been using a near glass here. These are his specs. Now when he starts developing a nuclear cataract or nuclear sclerosis, what happens due to the nuclear sclerosis? Hardening of the nucleus. We have just read it. And this will lead to increased index of the lens. And when there is more index, power of the lens will be more. And if there is more power, there will be more power in the lens. I need lesser power in my specs. No? Therefore, there is improvement of glasses. Because now I need lesser power in my specs. Okay. So, these improvement of near glasses is what is called as second sight of old age, but it is happening due to nuclear sclerosis. So, why we have to mention this? Because the moment the cataractus change will increase, definitely the patient is not going to be happy. He will have some other visual problems, far vision will be less, blurring of vision will start. But it's a very early case where he is not realizing any problem of vision. But the index of the lens has increased. In such a case, what is happening? There is improvement in near glass. I think this much is enough to understand about what is second sight of old age, and your answer should be nuclear sclerosis or nuclear cataract. Okay. This was about your nuclear cataract. We next talk about is subcapsular cataracts. So talking about subcapsular cataract. We are still discussing senile cataract, don't forget that. So when you say subcapsular, it can either be anterior subcapsular, just talked about, right? Or it could be posterior subcapsular. So let us write a few points here. Anterior subcapsular is due to fibrous metaplasia of anterior epithelial cells. A little bit of information here. Fibrous metaplasia of anterior epithelial cells. That's it. Okay. Anterior subcapsular we are going to learn in toxic cataract. Right. Where else you get anterior subcapsular? We will talk about it. We next talk about is posterior subcapsular. One thing we already know about this is the causing maximum diminution of vision. PSC causes maximum diminution of vision. How is this PSC formed? Again, now write down. It is due to dysplasia of E cells. Now, this dysplasia of E cells, and so it is migrating here and causing, so this dysplasia of E cells which migrates, which is nothing but migrating from the anti-epithelial cells, isn't it? E cells. E cells are what? Anti-epithelial cells. This is causing PSC, and the name that you should be familiar with, these are called Weddell cells or bladder cells. Just remember this much, Weddell cell or bladder cells. Correct? So that was about one point about PSC. Also remember, PSC is one cataract which is going to create problem both in the day and night. So in the night time, when there is dilatation of the pupil, there is a lot of scattering of the light and there will be a lot of glare. Okay, and at the daytime also, it is due to constriction. Again, it's a central cataract. It will cause diminution of vision and diminution of near vision. So it is causing problem. We will write this in clinical feature. That was about PSC, correct? Okay, so once we know this about subcapsular cataracts, we next talk about is second type, metabolic. But before that, we'll see the slides. Okay. And also, we can write one more point here that PSC is also called cupuliform cataract. I'll just show you. Cupuliform. What are you seeing in this slide are nothing but the stages of the cortical cataract that we have learned. So, what are the cortical cataracts we have learned? Is stage of lamellar separation, incipient cataract, immature, mature, hypermature. Can you see that? Little. So, when there are spokes, it becomes incipient. Correct? Now, immature means now there are cataractous opacities which later becomes mature. This is your hypermature, and now you can very well know about hypomature Morganian. Let's see the next slide. Again, this seems to be a mature cataract here. You want to write it? You can write it. This one I showed you earlier also. This is your Morganian cataract. Look at this one. So this is the slit lamp light here. And this opacity that you are looking at all like this. Can you see this? Appreciate this. This is posterior subcapsular cataract. Just ignore this. This is reflection of light. So this posterior subcapsular cataract is what we also call cupuliform. The other name of this cataract is cupuliform cataract. This is also a PSC. And what do you look here? So this is your corneal slit I've shown you. When it is falling on the lens, this is the section of the lens. I can see the cortical part, I can see the nuclear, and we can see how the nucleus is opaque here, right? So this is a nuclear cataract, but we are still not seeing any deposition of pigments or colored, or this one is not colored, I mean to say. But look at this one. So now this is again almost brown. This is also nuclear cataract. So this is a corneal section, and when it falls on the lens, all this part nuclear, and after that this is all involved, but primarily it has involved the nucleus. So it's a nuclear cataract. And here when it becomes pigmented and it becomes black in color, which we call nigra, right? So this is a nuclear cataract, which is okay. Then we talk about, we have already discussed this accommodation part. Again, this is a mature cataract. And here comes your hypermature Morgagnian again. So we'll come to the next type of cataract, and that is metabolic cataract. We talk about metabolic cataract. I'm making things very easy for you. Metabolic, most important we will learn is diabetes. Okay, so first heading is diabetes mellitus. 4 important points, all are exam questions. So we will write in this way. This is how I make things easy for you. Just write point wise, flow chart wise, make diagrams, you are done. So make a Q. All 4 are exam question. So if you understand, why will a diabetic patient develop a cataract? What is happening? Let's try to understand this first. So why a diabetic patient is going to develop cataract? Let's understand this first. So what is happening? Too much of glucose? Too much of glucose, all the metabolic pathways are exhausted. And that means Krebs cycle, pentose phosphate shunt, glycolysis. When all are exhausted, what is left is sorbitol pathway. And there is sorbitol accumulation in the lens. Now this sorbitol accumulation, this sorbitol is very, very hyperosmotic. It is going to imbibe water, leading to cataract. Okay, so diabetes mellitus, first question, why cataract? Write down, due to sorbitol accumulation. This sorbitol accumulation, sorbitol being hyperosmotic, we all know hyperosmotic, any hydration will lead to cataract. Second question they have asked you is, what is the enzyme responsible for this sorbitol pathway? So enzyme responsible, write down, is aldose reductase, NADPH dependent, NADPH aldose reductase. Right? Third question, very, very important, repeated. Let's put a Q, one more Q here. And that is, what is the type of the cataract? Type of cataract we will answer is snowflake or snowstorm cataract. Snowstorm or snowflake. The opacities look like snowflake. Let's have a look. So these are the snowflake or snowstorm cataract. Right? So this type of morphology of diabetic cataract, next question, is common in which type of diabetes? Is it type 1 or is it type 2? So here we will answer this snowflake and snowstorm is more common in type 1 diabetes. Okay, this was your next question, type 1 diabetes mellitus. Right? So these are the 4 important things that you have to know about a diabetic cataract. Anything else we can think of we have to discuss in diabetic cataract? We just talked about presbyopia. So it crosses my mind. There is a very important exam question about frequent change of presbyopic glasses. So again and again the number is altering. What can be the causes? So if you talk about the frequent change of presbyopic glasses or frequent change of glasses, but generally we say presbyopic glasses, right? So one important, of course, just learn like this with me. 3 main causes. early cataract, late glaucoma, and that is late stage of primary open angle glaucoma. We'll discuss this in the glaucoma chapter. And third, diabetes mellitus. So what is the trick here? Many of you will answer diabetic cataract. It is not diabetic cataract. It is diabetes itself which is causing frequent change of presbyopic glasses. So it is not diabetic cataract but the disease itself. Why? If there is more glucose, what is happening? Swelling of the lens. Any swelling of the lens, think yourself, is going to cause more curvature. When there is more curvature, more power. So hyperglycemia, when you say more power, or going towards more power. What do you call that? Myopic shift. Okay, so we can learn it here that if there is a hyperglycemia in this patient, if he is hyperglycemic, there is myopic shift. And vice versa, if suppose the sugar goes down, hypoglycemic, we have hypermetropic shift. Hypermetropic shift. Correct? So, this is very, very important. We are going to put a Q here, all of you. And we are going to put another 2 Qs here also. What are the causes? Now, so that was about diabetes. Now, they will also ask you, why am I teaching you early cataract? So, exam question, I'm quoting it for you. The question was, frequent change of presbyopic glasses is an early symptom of. And all 3 were given. All 3 are the causes. But the catch point was early symptom. It is cataract. That's why we have now started learning as early cataract, late glaucoma. What do we mean by early cataract? Intumescent. So when the water is more, swelling is more, it's a myopic shift. When the water is less, hypermetropic shift. So ultimately, it is mainly we are talking about early stage of cortical or intumescent cataract, where the amount of water is varying and therefore the refractive error is changing. So also keep in mind in your OPD, suppose you take ophthalm in the OPD, you get a patient who is diabetic. First thing you should do before giving him specs is to check his blood sugar. Isn't it? So if he is hyper or hypo, please delay the test. Don't be in hurry. Otherwise, after a few days only, he is again going to complain that he is not able to see clearly. So all the refraction should be done when the blood sugar is normalized. Okay? Right. And late stage of primary open angle glaucoma, it's a factual thing. You have to just know it. It can present with frequent change of glasses. Right? Okay. That was your diabetic cataract, which is the second metabolic we will learn is galactosemia. We talk about galactosemia. Galactosemia, it can occur due to galactokinase deficiency or GPUT deficiency. What type of cataract? So we are going to learn 3 important things. If it is due to galactokinase deficiency, this will lead to lamellar cataract. Please make the arrows and write, it helps. If it is due to, now this one is exam question. If it is due to GPUT deficiency, GPUT stands for what? Galactose phosphouridal transferase. Okay? It is galactose phosphouridal transferase. So, if it is due to this will lead to oil droplet cataract. Okay? So, what we are going to get here is oil droplet cataract. Third important thing, also an exam question, they had asked you once, which is a reversible cataract. So cataracts are not supposed to be reversible at all, but only name if I can take is for galactosemia, as it can be, not always, it can be a reversible cataract. Okay, so this is another Q. These are the 2 Qs, keep in mind. Right, so that was about galactosemia. Let's have a look. See this. This is what is oil droplet. It looks like a drop of oil in the lens, isn't it? So this is oil droplet cataract. Okay, come to the next metabolic. What is the next metabolic which is very important to learn? Chalcosis, or some of you pronounce it as chalcosis, whatever you want to. I call it chalcosis. So, chalcosis or chalcosis is nothing but copper alloy in the eye. It's not pure copper. Pure copper will just lead to blindness, okay? It causes phthisis bulbi. What is phthisis bulbi? Blind shrunk eye. So this is copper alloy in eye. So this copper alloy in eye, generally cuprous oxide. Anyway, so this is what is chalcosis. Why will it happen? We all know this so well. Etiology could be either a copper containing foreign body. Copper containing foreign body. Write down. Hope you're noting with me. This is the reason I write in the class so that you can write along. Okay. Please do that. It is very, very important. I have already told this in my initial lecture. So this is copper containing foreign body, or another cause will be Wilson's disease. Right? So another cause is Wilson's disease. How will it present in the eye? Two main features that we will not forget are exam questions. We will make two cues. One is sunflower cataract. Okay. And second, very important, we all know this, Kayser-Fleischer ring or KF ring. Right? So have a look at this one. So this is your Kayser-Fleischer ring. KF ring or Kayser-Fleischer ring. What is it? This Kayser-Fleischer is nothing but copper deposition in the Descemet's membrane of the cornea. Okay. So this is looking like a golden brown ring near the limbus. This is what is Kayser-Fleischer ring. We will write this. Just see this one. Of course, this doesn't seem to be a very clear picture of sunflower cataract. So let's look at this one. So this is what is sunflower cataract. So this is your sunflower cataract. Right? Few very, very important points about Kayser-Fleischer ring or KF ring. Number one, this is an important, very recently, I think it is last year question had come in your AIMS exam for KF ring. So what they had asked you is all the statements are true except. So let's understand what were the statements and what was wrong. So first of all, important information that KF ring is copper deposition. Where is the copper deposited? We just learned Descemet's membrane. Now, we just saw that it is in ring form. Second thing, it will first start, make the diagram, it will first going to start superiorly and inferiorly. And then it will extend. So, starts superiorly and inferiorly. You learn in the cornea chapter that arcus senilis also starts superiorly and inferiorly first. So, keep that in mind. Come to the third point. It is found in all the cases of Wilson's disease with neurological complications. Okay, it's almost all cases with neurological complications will present with KF ring, right? Then next important point on KF ring, is it reversible or irreversible? And another exam question, we will answer reversible. Even if it is fading, it's a sign of reversibility. So this is what we look for when we are treating a Wilson's disease. And then next is this was the statement of your exam which was not correct, and it was written all cases of hepatic disorders in the Wilson's disease are associated with KF ring. This is not true. Only 65 to 67%, I don't want you to take the percentage in exact, it's variably written in different books. But yes, around so much, 65 to 67% of the patients will only present with KF ring. Rest of the patients may not have the KF ring. I'm talking about what? Hepatic complications are involved. Okay. So, next important thing is around 65 to 67% of the patients with hepatic involvement, I hope you're writing with me, will be presenting with KF ring. So not all patients, so this was a wrong statement and this was the answer of your question. So we can just give it a little more importance and write here, this has to be read properly, right? Okay, so this was about KF ring. Now tell me, very interesting, what is Kayser-Fleischer ring? What is Fleischer's ring? So what is Fleischer's ring? Spelling is exactly same, Fleischer, which we see in Kayser-Fleischer, but it's very different. What is Fleischer's ring? Fleischer's ring is, if this is the cornea, a condition where there is a conical protrusion of cornea is called keratoconus. At the base of this keratoconus, we see iron deposition at the base. And this iron deposition is what is called Flecher's ring. Okay? So this iron deposition at the base of the cone is what is called Flecher's ring. So it is not copper, number one. Which layer? Iron. Whenever they ask you which layer, it's always epithelium. Okay? So epithelium. Right? So it's a tricky question. Flecher is not case of Flecher. Good. So that was about calcosis. Come to the next. Which is the next metabolic cataract we will learn is Loeys syndrome. Now, Loeys syndrome is also called oculocerebrorenal. It is oculocerebrorenal syndrome. So, eyes are involved, brain is involved, kidney is involved. We have to, of course, concentrate on ocular features here. So, what are the ocular features of Loeys syndrome? First, of course, is metabolic cataract. Why do you call it metabolic? It's error of amino acid metabolism. Okay, so it's an error of amino acid metabolism. So we are getting cataract, number one. Secondly, we can also get small lens, that is microphakia. Right? Thirdly, what we get here is glaucoma. You can get glaucoma in these patients. And number four, very important exam question. Let's put a Q. Posterior lenticonus, conical protrusion of the lens, posteriorly. Posterior lenticonus. Okay, we'll draw a diagram here. All of you, please. So, this is the lens. We are saying posterior conical protrusion is posterior lenticonus. It is seen in Loeys syndrome. Now, on this diagram, we'll learn something more. Yes, we are going to learn where do you get. So, write down here, this is posterior lenticonus Loeys syndrome. Now, where are we going to get anterior lenticonus? Anterior lenticonus, we will answer, is seen in Loeys syndrome. I'm so sorry. Please correct it. I meant Alport syndrome. So, A for A, it is seen in Alport syndrome. Did I teach you A for A somewhere else also? So, if you are following the sequence and if you have attended my introduction wala lecture, so A for A, axial length is measured by A scan. So, that was one A for A I taught you. And this is the second one, anterior lenticonus Alport's. Correct? So, Alport syndrome is what? It is familial hemorrhagic nephritis. It's a familial hemorrhagic nephritis. There's another question. Anterior lenticonus. Okay, first let us put a Q here. This is also important Q. This is also important Q. Third Q is that anterior lenticonus is more common in males. Okay, this is also your exam question. Anterior lenticonus is more common in males. Another question. Anterior lenticonus, you can get oil globule reflex. We just talked about oil droplet cataract. So many oils here, huh? So now it is oil globule reflex. Let's see what it is. Have a look. So if you see here, this is the corneal section and this is the lens, and we can see the posterior conical protrusion. So we are looking at posterior lenticonus. So this is your posterior lenticonus. Right? Okay. Now look at this one. This is the corneal section. And what do you see? We see a conical protrusion in the anterior surface here. So this is a case of anterior lenticonus. Right? Okay. So this is your anterior lenticonus. We come to the next is, this is what is oil globule reflex. Kya hota hai oil globule? When I'm looking through the slit lamp, and can you see the fundus glow? Right? That red glow that you see, that means I'm looking in retroillumination. Which means the line of my sight where I'm looking and the illumination are on the same line. Okay. So there are two limbs in a slit lamp. We all know that. One, the eyepieces through which we are seeing, and another is the source of illumination. So when the eyepiece and source of illumination, they are in the straight line, then this is retroillumination. And what are you looking here is, can you see this, appreciate this round circle? This is what is called oil globule reflex. Okay? So this is your oil globule reflex. So oil globule reflex is feature of, it's a Q, we will answer, anterior lenticonus. So making things more interesting. So we have already learned 2 oils. We learn another oil. So write down all the oils in ophthalmology. One oil that we learned was oil droplet cataract. Yes, it is a feature of galactosemia. Come to the next one. Oil globule reflex. This is a feature of anterior lenticonus. This much we know. Now I am telling you one more oil which is a reflex, and this time we call it oil droplet reflex. So when you say oil droplet reflex, this is a feature of keratoconus. We will see a dark shadow where there is a conical protrusion is starting. So what you have to remember, we will talk about it in cornea, that's a feature of keratoconus, okay, number 1, seen as a dark shadow through what? These are slit lamp findings. This I am seeing through slit lamp. This also I am seeing through slit lamp. But when I talk about oil droplet reflex, it's a finding of distant direct ophthalmoscopy. Do we know what is direct and indirect? We have discussed in introduction. So when the same direct which you take very close to the eye and see, right? This is how you use a direct. We take very close to the eye and see. Now see what? Central retina. Now when the same instrument is seen at a distance, where you are seeing the media and the media opacity, now this is what is called distant direct ophthalmoscopy. So when I am doing a distant direct ophthalmoscopy in a patient of keratoconus, I can get an oil droplet reflex. Correct? Okay. So that was about that is your Loeys syndrome. Another metabolic cataract which needs mention, that it can also occur due to hypoparathyroidism. Keep this in mind. Right? Leading to hypocalcemia, and this could also be a cause of metabolic cataract. So that was metabolic cataract. Now what was the next type? Next type is complicated. Let's give the next heading. Complicated cataract. Complicated cataract is also called secondary cataract. Now think yourself. What does it mean? Cataract which is occurring as a complication to either anterior segment disease or posterior segment. Right? So that is what is called complicated. Okay? So that cataract which is occurring as a complication to the disease is called complicated cataract. So can we make it simple here? That cataract occurring as a complication to anterior segment disease or posterior segment disease. Right? When cataract, make the diagram and write like this, and therefore cataract occurring as a complication. This is what is complicated cataract. Okay, so if we know this, what can be the anterior segment diseases and posterior segment? A little bit of the idea we should know. So, anterior segment diseases that most important and most common will be anterior uveitis. Okay, chronic anterior uveitis. So, can we write it here? Anterior segment diseases may most important, most common is chronic anterior uveitis. We are going to learn its detail in the uveitis chapter. And we are giving steroids to treat uveitis. Even that becomes a cause of cataract. We all know steroids can lead to cataract. Okay? Second, we should know the cause. It could also be high myopia. That is also one cause of cataract. So, high myopes and pathological myopia are prone for complicated cataracts. Okay, they are generally posterior subcapsular. So, this diagram will help you to learn all the important etiologies. And then another important posterior segment disease apart from this would be hereditary fundus dystrophies. Okay. So, when you say fundus dystrophy, We are talking about most important retinitis pigmentosa. This is a very important topic for you all. We'll deal it in retina chapter. Retinitis pigmentosa, again it is PSC. Okay. Then another that you will know, let us learn about gyrate atrophy. We will learn about gyrate atrophy as a cause of night blindness. It's a choroidal dystrophy. Okay. Then you can know about, I'm writing it here. Number 3, Leber's amaurosis. What is amaurosis? Did we talk about this? Amaurosis means total loss of vision. So this is, it's again a hereditary dystrophy. And one more that you should know is your Stickler's syndrome. These could be some causes. This is again a collagen disorder. Stickler's syndrome. Most common ocular feature of Stickler is retinal detachment. Keep this in mind. Okay. So, if you talk about the most common ocular feature, it is RD. Anyway, this becomes a different thing altogether, but just keep this information in mind. So, these are some important causes why patient can develop complicated. Very important. Give the next heading, clinical features. First, very, very important question is, what is a pathognomic feature of complicated cataract? What is a pathognomic feature of complicated cataract? P for P, polychromatic luster. We answer polychromatic luster. What is polychromatic luster? Multiple colors are seen, right? So, when you're looking at the section of the lens, there are poly is multiple, chromatic is color. Okay. So, multiple colors may be seen. Second, the opacities are, so if you want to write like this, even this is okay. Opacities are breadcrumb opacities. Okay. And with polychromatic luster, this is what is complicated cataract. Whenever they ask you the pathognomic feature, it has to be this one. Polychromatic luster. And then let's also understand, they have asked another, so this is a Q, right? This is a Q. Another Q is about which is the most common type of complicated, it is PSC. We can see that it is PSC. Also one more anti-segment disease you can also write it is glaucoma, mainly angle closure glaucoma. So write down glaucoma or angle closure glaucoma. Right. So this was especially when there is an acute attack of angle closure, there is a lot of inflammation, it may lead to later as complicated cataract. Now, next we talk about, so these are the points we have to remember. Let's have a look. So this is your complicated cataract, okay, with breadcrumb appearance. So this section is that of the cornea, and then when it is falling in the lens, this is how it looks so colored. Okay, so we come to the next type of cataract is toxic cataract. Next type of cataract is toxic cataract. When you say toxic, it means due to drugs, right? So when I say toxic cataract, what are the drugs or medicines which can lead to cataract? Everybody knows first what we have to mention is always steroids, right? So steroids are actually causing disturbance in the osmotic balance, and because of disturbance in osmotic balance, it leads to cataract in the lens. What is the second? Second you will learn is phenothiazines. Third, long-acting miotics. Long-acting miotics. Right? Then number 4, amiodarone. Number 5, busulfan, chloroquine, and lastly write down gold. Gold you use in rheumatoid arthritis, so gold. Correct? You have to be familiar with the list. There is no other option. So long-acting miotics, phenothiazines. So what are long-acting miotics? All of you. This is one question. Majority of you are not able to answer at this stage. Maybe you've forgotten all your pharma part. So we have to revise from KDT a little bit of things like mediatic, miotics, and cycloplegics, so that we are clear in the future chapters. Just go through it. Make an effort. Go through it. 1 or 2 pages about miotics, mediatics, and cycloplegics. Just revise it, please. So long acting or short acting is pilocarpine, and long acting will be like phospholine iodide, DFPs, ecothiophate. So we are talking about long acting miotics. Correct? Okay. Now next thing that they want to know from you is type of cataract. So very simple to learn. See, steroids cause PSC, and busulfan and chloroquine also cause PSC. Rest all will lead to anterior subcapsular cataract. Rest all are causing anterior subcapsular cataract. We mentioned about subcapsular. So anterior subcapsular cataract. How do you remember? This is a very known mnemonic. We can all learn this. BSC causes PSC. BSC stands for busulfan, then steroids and chloroquine. We don't need too many mnemonics here and there. Too much of mnemonics can also be very confusing. Concept should be clear, but yes, few of them will help you more, right? Yeah. So write down busulfan, steroids and chloroquine. Okay, so this causes posterior subcapsular cataract. So I am discussing one exam question here. Most common complication of steroids in eye. Writing for you, write down most common complications of steroids in eye. What should be your answer? Please answer glaucoma, not cataract. So if you started answering glaucoma, next year the question was which type of glaucoma? Again, your answer should be open angle glaucoma. Right? So what it does is it is actually causing deposition of mucopolysaccharides in the trabecular meshwork. So leading to open angle glaucoma. So it is hampering the trabecular outflow. So we are going to discuss these details in glaucoma chapter. Another question for you. What is more common after systemic steroids? What is more common after topical steroids? So after systemic steroids, what is more common is? Now you will answer cataract. Which cataract? PSC. And after topical steroids, more common is glaucoma, that is open angle glaucoma. These are important questions. We need to learn them. Okay, so the next is your traumatic cataract. So our next heading will be traumatic cataract. When you say traumatic cataract, there are three broad headings we have to take care of. What are the types of trauma or injury in the eye? Perforating, right, or penetrating injury. Second is your blunt trauma, which is called concussion injury. And one more thing that needs a mention is your electric cataract. So, perforating injuries, if this perforating object is hitting the lens, right, then definitely it will lead to cataract. Second, I said blunt trauma. Lot of questions, very important. Blunt trauma. Also called concussion injury. Right? Concussion injury. Let's make a cue here, all of you. 2 cues here. Very important. So there are 3 main things that we have to keep in mind regarding blunt trauma, and all 3 are exam question. Let's put the cues. So first is your which type of cataract? It is called rosette shaped cataract. Okay, it is called rosette shaped cataract. Another question. Rosette shape involves which part of the lens? Mainly posterior cortex. It involves posterior cortex. Starts from posterior cortex. Come to the next one. Next question here. What is Vossius ring? I think this was one of the very important short notes in your MBBS as well. So Vossius ring. What is Vossius ring? Common sense. Let's first understand before we move further. So whenever there is a blunt trauma, what is happening? Iris touches the lens and comes back. Now the posteriormost layer of the iris has pigments. So these pigments are going to get stuck on the anterior part of the lens, anticapsule of lens. And that is always in the shape of pupil in form of a ring. Okay. So this is what is called Vossius ring. Like this. So these are iris pigments on this is the Vossius ring. imprint of, you write it like this, imprint of iris pigment on the lens. So when it is on the lens, which part of the lens? This is your next question. Of course, anterior capsule. So it is seen in anterior capsule. Okay, so it is a feature of, it is seen in the anterior capsule. This is what is Bosier's ring. It's a feature of blunt trauma. We come to the third question, which is also very important. Whenever there is a blunt trauma, there can be edema at the macular area. We have learned this, that macula is the central retina. So this edema at the macula is what is called Berlin's edema. Again, this has been a very important short notes for MBBS. What is the other name of Berlin's edema? It is also called commotio retini. It is also called commotio retini. And how does it look like? Due to the edema, the typical morphological feature is a red spot at the center in the macula. This is what is compared to a cherry. We call it cherry red spot. So we are going to learn a lot of causes of cherry red spot in your retina chapter. Abhi ke liye just learn that Berlin's edema, commotio retini is edema at the macula due to blunt trauma, and it looks like cherry red spot. Correct? Okay. Then we talk about next is, after this we will talk about, these are the three features of the blunt trauma. What about electric? So electric shock can lead to electric cataracts, right? And electric cataracts are generally anterior subcapsular and typically stellate in shape. So they are stellate and they are anterior subcapsular. Let's have a look. Look here. So this is your rosette shaped cataract of blunt trauma. Okay, so this is rosette shaped cataract. This is your slit light. This is your slit beam from the slit lamp, which is your corneal section, and when it falls on the lens, this is how it looks like. चलो उसके बाद next हम लोग पढ़ते हैं. Of course, if there is a blunt trauma, this is also one thing. I'm going to discuss this in your ocular injuries. So what is this you're looking at? Can you see that iris is disinserted from its root? And this is due to blunt trauma. We call it iridodialysis, right? And I can see, therefore I will call, this is also traumatic cataract. Blunt trauma may, I cannot appreciate the rosette shape, but definitely it's a traumatic cataract. Another interesting thing that you can see here is that now the shape of the pupil is not round. It is more like a D-shaped pupil. So in iridodialysis, this is important exam question, we get D-shaped pupil. Yeah, so this is little out of the way, but because it is in front of us, we should learn it. So D-shaped pupil is a feature of iridodialysis. Okay, and when there is an imprint of the iris pigment of the lens, this is what we call as Bosier's ring. And what else we have to know? This is present on the anterior capsule of lens. This is the red spot on the macula due to blunt trauma. This cherry red spot will be a feature of Berlin's edema or commotio retini. Correct? Okay. That was your traumatic cataract. And yes, what about electric? Have a look. So these are the stellate opacities. This is what is electric cataract we have been talking about. So the next type of cataract we are going to learn is radiational. When you say radiational cataract, first important thing, please remember, radiational cataracts, all electromagnetic radiations will lead to cataract. Okay, can we write this? All electromagnetic radiations. So one way of asking the question is, will it happen after CT scan? Yes. Will it happen after MRI? No. So this is one way of asking. The second question they've asked you here is your most common type of radiational. It is again PSC. Most common type of radiational is PSC. Another thing that needs a mention here is what is glass blower's cataract. Now, glass blower's cataract is in a glass factory. People working in the glass factory are exposed to infrared radiations, and this can lead to cataract, which involves cortex as well as posterior subcapsular area. Okay, so there are cortical changes and there can be posterior subcapsular changes. This is what is called glass blower's cataract. cortical and posterior subcapsule. Right? So this is what we have to know about radiational cataract. Okay, suddenly I remember one question. From the retina, they have asked you which is the most radio-resistant layer of the retina. What will you answer? Let us see. Most radio-resistant. So if I talk about retina, most radio-resistant layer. And which is the most radio-sensitive layer. So we are going to learn it in what the layers of in the retina chapter. Just remember this, ganglion cell layer is most radio resistant and photoreceptors, that is rod and cones, are most radio sensitive. Okay? So ganglion cell layers are most resistant and rods and cones are most radio sensitive. And if I ask you for the whole eye, then again very simple. If I am talking about not one structure like retina, but in the eye overall, you will say sclera is most radio resistant. Okay, radio resistant sclera, most radio resistant. And most radio sensitive structure of your eye is lens. Okay, this is lens. Please remember this. Right. So when we are saying about electromagnetic radiations and we are talking about that any electromagnetic radiations, all types can lead to cataract. I want to ask you, what about microwave? Will microwave lead to cataract exposure? Any radiation from the microwave will also can cause radiational cataract. Keep that in mind. Don't keep peeping inside. So you never know if some radiations are leaking or not. Huh? Anyway, so that was about your radiational. Did you realize we have learned PSC so many times now? So we are going to put them all together to know what are the questions asked in PSC in your exam. One important question. Most common type of, just now we learnt radiational, we will answer PSC. What was the other name of PSC? Cupuliform cataract. Okay, then next question was most common type of complicated cataract. Again our answer was, or secondary cataract was PSC. Third question of your exam, steroids cause which type of cataract? It is PSC. Rather we can learn here BSC causes PSC. All three drugs, busulfan, steroid and chloroquine cause PSC, but the question was on steroid only. Anything else we learned about PSC? So it is one cataract which is affecting both type of vision, day and night. We also learned about this is causing maximum diminution of vision because it is near the nodal point of the eye. Right? Okay. So that was about your different types of acquired cataract, a long list of course. Let's talk about cataract associated with systemic diseases. Okay. So our last type of cataract, type of acquired cataract that we are talking about. So cataract associated with systemic disease, or these we are calling it, this includes what? It is pre-senile cataract, right? So what is pre-senile? I think we had mentioned this. Pre-senile cataract means cataract in less than 50 years of age. So let us learn the causes of the pre-senile cataract. So the first cause of course is diabetes, which we have already done in detail. Second is myotonic dystrophy. So second is myotonic dystrophy. We all know it's a myopathy. So if you have learned in your medicine, a tight grip, inability to relax, and also just revise your medicine part. Myotonic dystrophy is one of the most common muscular dystrophies. Okay. So what are the ocular features? There are many ocular features of myotonic dystrophy. So let's learn the ocular features. So ocular features, first can I just mention the question? The question they had asked you is type of cataract. First let's make a cue. So the type of cataract we will learn is Christmas tree cataract. Christmas tree cataract. Because the opacity they look like a decorated Christmas tree. Let's have a look. See here. So these are needle-like chromatic, so colored look, hai na? So these are polychromatic needle-like opacities. That's what we say. Multicolored and they look like needle-like. Can you appreciate that? So this is your Christmas tree cataract. It can be cortical, it can be posterior subcapsular, area can also be involved. Got it? So can we note it down here only? That these are polychromatic needle-like opacities. Polychromatic, multiple colors again. So how do you differentiate from complicated cataract? Of course, everything around it, the history, the other findings will help me to know, okay, is it myotonic dystrophy or am I talking about the polychromatic luster of complicated cataract? Correct? Okay, so this is polychromatic needle-like opacities. This is mainly we are talking about is myotonic dystrophy. So once we know this, see another slide. So this is also your needle-like polychromatic opacities. So this is also myotonic dystrophy, Christmas tree cataract. We call it Christmas tree cataract. I said it can be cortical and may also involve posterior subcapsular area. Then we were talking about the other ocular features of myotonic dystrophy. So I want you to make the diagram and label it. That will become easier for you. So all of you make a diagram. I'm making it here for you. And let's label it. So outside the in, if you think, because it's a myopathy, it involves the muscles. There is ptosis. We all know ptosis is what? Drooping of eyelid. So see, it's very easy to learn it as 5 P's. So what are the 5 P's of myotonic dystrophy? First P is ptosis. But make a diagram, okay? Then of course pre-senile cataract, which is Christmas tree. Another P is pre-senile cataract. And write down, this is what is Christmas tree cataract. This is the Christmas tree cataract. Correct? Then because of the myopathy, your intraocular pressure is low. So we can just put it here, low IOP. So another P for pressure. Correct? Then pupils. Pupils are showing miotic pupil reacting slowly to light. So pupils, another P. So there is miotic pupil. And it is slow reacting. And the last one on the retina, what do you get is another P, and that is pigmentary retinopathy. Pigmentary retinopathy is also called as salt and pepper fundus. Okay, we are going to learn it in the DD of salt and pepper later on when I am taking congenital cataract. So salt and pepper fundus means nothing. When you are looking at the fundus, it feels as if the whole black pepper is all around, which is nothing but pigmentary disturbance. Right? So this is what is pigmentary retinopathy or salt and pepper fundus. So these are the features. If you just draw a diagram and label it, it will be easy for you to understand. Right? Okay. So once we are done this, what is the other pre-senile that we needs mention is, write down in the list is atopic dermatitis. What type of cataract is exam question? So this is what is the cataract of atopic dermatitis involving the whole of the pupillary area like this. This is the part, of course, which part of the lens? It is anterior subcapsular opacity. We called it shield cataract. Okay, so you're looking at shield cataract. This patient is a case of atopic dermatitis. So one was diabetes, second myotonic dystrophy, third is your atopic dermatitis, and fourth write down is your neurofibromatosis type 2. And this is what type of cataract? Posterior subcapsular. And this is also an exam question. They've asked you this way, which is the most common ocular feature of NF2. I'm going to take this again in the orbit chapter. This is PSC. And what is the most common ocular feature of NF1? I think we all can think of leash nodules, right? These are hyperpigmented nodules, hyperchromic on the iris. So leash nodules becomes, so just know these questions. It's important. So that was about your pre-senile cataract. Now we will discuss about clinical features. How will a patient of cataract present? Common sense, initially he will present with blurring of vision because of the opacities. So give the heading clinical feature. So initial presentation would be blurring of vision, and later this blurring of vision will progress into diminution of vision. Right? What is diminution of vision? So do we know all about the Snellen's chart? We go for an eye test and we are reading CTPA, LOD and HOBUC. So if you can read the last line, what is your vision? 6 by 6. Let's have a look. Okay, before that, just have a look at this one also. This is a slide for glass blowers cataract. You need to have a history around it to pick it up. Otherwise, it will be confusing. Okay. Now, this is what I was talking about when you say diminution. So, if you look at the Snellen's chart, the last line is 6 by 6, correct? So, 6 by 6, 6 by 9. I'm going to go around all the details in the optics chapter. But you have to know this very, very clearly. When you say 6 by 6, 6 by 9, 6 by 12, which is normal, denominator or numerator? So, it is always the denominator. Your patient is sitting at 6 meters, so 6 numerator is constant. But when I say 6 by 9, suppose, it means a normal person can read this CTPLO, this size of letters from 9 meters, which my patient can only read from 6 meters. If I say 6 by 18, now this size can be read from 18 meters by a normal person, which my patient is reading only from 6 meters. Okay, so be very, very clear about this first. Many of us are confused regarding this also. So this is how we depict a visual acuity by comparing with the normal. Now when I say diminution of vision, any DV means vision of less than 6. Anything less than normal, it could be anything. 6 by 9, 6 by 12, 6 by 18 and so on. Anything less than normal is diminution of vision. Okay, so we are going to learn in the retina chapter about what is disturbance of vision later on. Anyway, so we are saying there is diminution of vision where vision is less than 6 by 6. And what else we learned in diminution of vision? Let's think one by one. If it is a nuclear cataract, do we realize it's a central opacity? So you generally get day blindness or day vision is impaired. Day blindness is called hemerotopia. We'll talk about the causes in the conjunctiva chapter. So this, or you can say diminution of vision, particularly in the daytime. And when it is too much, it may lead to day blindness. Okay, that was about nuclear. Okay, therefore cortical cataract, vice versa, cortical changes are going to trouble you more at night. So this diminution of vision is more at night. The problem will be more at night. And what about PSC, subcapsular mein? We already know this. Glare at the night, even daytime there is a problem. I have told this again and again, both. So at night, glare is a problem. And in the daytime, there is diminution of vision due to meiosis. And there will be difficulty in near vision. Diminished near vision is affected. Right? So this is how a patient of cataract is presenting. What is the third thing he can present apart from glare? Glare we have already mentioned is polyopia. What is polyopia? Diplopia means double vision, 2 images. Polyopia means more than 2. Okay, so this is your cue. Let's be alert here. They've asked you that in which condition, in which stage of the cataract we get polyopia. We will answer incipient cataract or sometimes in intumescent. Actually, both are correct. Now, there was a question of your PG where among the two you had to choose only one. In that case, I will choose incipient cataract. Okay. What else? Colored halos. So, when the patient looks at the light, he can see colored rings around it. That is what is called colored halos. Right. So, colored halos has been a very important question and we have to be clear about it. What can be the causes of colored halos? 3. First is, of course, cataract. Second, what is the cause? We will answer acute congestive glaucoma. So acute congestive, which is also called acute primary angle closure. So this is a new nomenclature. So anyway, acute congestive glaucoma is the second. Many of you will answer glaucoma. Why it is wrong? It is wrong because glaucoma is a very broad term. So there is a reason why it is happening in acute congestive. What is that? In acute congestive stage is a stage of glaucoma where pressure, intraocular pressure may rise up to 60 millimeter of mercury. Now what is the normal intraocular pressure? 10 to 21. This is too high. So what? What is happening is now it is more than the corneal stromal pressure. Okay, so what is the stromal pressure in the cornea? Around 53 to 55 mm. Suppose it is around, it varies from 53 to 55 mm of SG. So whenever the IOP is less than corneal stromal pressure, of course it is not causing an edema, but when it is reverse, IOP is more, this leads to corneal edema, and this is the cause of scattering of light leading to colored halos. So colored halos will not happen in any other type of glaucoma but in acute congestive glaucoma. Then we talk about what is the third cause. Third cause we will write here. So first is cataract, acute congestive glaucoma, and third, don't say conjunctivitis. Again, it's a wrong answer. We have to specify. It is mucopurulent conjunctivitis or purulent conjunctivitis. Why? Because if it's a watery discharge is not causing diffraction of light. But when it is a mucopurulent conjunctivitis, this mucopurulent conjunctivitis is leading to diffraction, or you can say scattering to be more accurate. This scattering of light is what is leading to halos or colored halos. This scattering of light leads to colored halos. Right? So what was the next? Mucopurulent conjunctivitis will lead to scattering of light, which is causing color. Got it? So these are the three causes. Come to another question. They have asked you this, what is Fincham's test? This is a test to differentiate between are the halos due to acute congestive glaucoma or it is due to cataract. So what do you do? Suppose I am the patient and I can see the halos. Now you pass a stenopic slit in front of my eyes, right? So looking through the slit, if the halos are breaking, then it is cataract. If not, it is acute congestive glaucoma. Okay, let me explain. First of all, what is a stenopic slit? So when you go for an eye test, the lens by which your eyes are closed, what is that called? That black one? Occluder, isn't it? And any small hole inside that occluder, what is that called? Pinhole. Similarly, there can be a long slit which is called stenopic slit. Let's have a look. Look at it. So this is your stenopic slit. So this stenopic slit, as you see here, when you are passing in front of the patient's eye, what happens? See, now stenopic slit is passed through the pupillary area like this. The halos are making and breaking in different shapes. If this is happening, actually this is a case of cataract. And if this is not happening, it is a case of acute congestive glaucoma. What is the basis? See, acute congestive glaucoma is due to corneal edema, which is all uniform throughout. So no baking and breaking. But when it is cataract, common sense, it has to be immature cataract, then only I can see something. What about colored halos? So somewhere there is a opacity, somewhere it is clear. So therefore the behavior of the halos are changing. Okay? Okay. Should we write this? Write it. So we will write like this, passing stenopic slit. When you pass the stenopic slit across the pupil, two things are happening. Halos break or not break. Break or not break. Right? So, likho, if it is breaking, it is due to cataract. Not break, it is due to acute congestive glaucoma. Not break, it is due to acute congestive glaucoma. Good. So that was Fincham's test. So this is how the patient of cataract can present. Next we talk about is treatment. So when you talk about treatment, is there any medical treatment for cataract? Do we have some medicines? No. Okay. What about for prophylaxis? Again a big no. Everything that you're at your place, if people are putting, especially it's a very common name, Catalan. All these are placebo. It is not doing anything. Okay. So please take this. The takeaway message here is that there is no role of medicine in either prevention or treatment of cataract. So the only option is surgery. So now we are going to talk about what are the different surgeries for the cataract. Okay, one by one. First we will learn about is ICCE. Okay, so when you say ICC, it stands for what? Intracapsular cataract extraction. Intracapsular means including the capsule. So, intracapsular means that this is the lens and this is the capsule and you're including both. So, it's an intracapsular cataract extraction. Written? So, when you say intracapsular, what do you actually do? Suppose this is a dilated pupil. We all know we sit at the head end of the patient to operate. This becomes a 12 o'clock position and this is your 6 o'clock. 12 o'clock is where we are sitting. Okay, so what we do is you open this, make a full thickness cut from 3 to 9 o'clock. This full thickness cut that you are making at the limbus. Once you have made this full thickness cut, hold the lens. Now go for a little sideways movement to break the suspensory ligament and slowly take it out. So, and once you have taken it out, then you suture the section with radial sutures. This is what is ICC. Now, how you hold the lens and take it out, there are different methods. Right? So, what are the methods of doing an intracapsular cataract extraction? First, I can hold it with Aruga's forceps. When I hold it with Aruga's forceps, we call it forceps extraction. Forceps extraction. Second, you can say is cryo extraction. So this time I'm using cryo probe. This cryo probe, please remember, is minus 40 degrees centigrade. So cryo extraction where I'm using a cryo probe. Number 3, I can use a spoon-like instrument like this. Okay. And this is what is called wire vectis method. So the third method, this is a wire vectis. So it becomes wire vectis method. And suppose I'm not using any instrument, just with pressure at the 12 o'clock, counter pressure 6 o'clock, 12 o'clock, 6 o'clock. Now this is what is called Indian Smith method. So with pressure, counter pressure, this is what is Indian Smith method. Right? So these are the methods of ICC. Okay, so once you know what is intracapsular cataract extraction, there are 3 very important questions. First question is, which is the best method? Which is the best method? We will answer cryo. Okay, so write down best method is cryo. Okay, the next thing they will ask you is, what is, do you realize this, that I don't want to do this surgery today? In these days, why will I want to do this surgery? I will not have any capsule with me. How am I going to put an intraocular lens? We don't do the cataract surgery without IOL these days. So, unless and until it's too much of an, there is some specific indication, right? So, next thing they will ask you. So, 2 more cues for you from ICC. What is the only indication of ICC today? Only indication of ICC, we will answer is, of course, when you can't save the capsule, majboori hai. Okay, so now you are helpless, you have to remove it. It is subluxation of lens. Okay, so subluxation of lens, especially if you want to know this, more than 9 clock hours, then it is indication for surgery. Okay, then third is your very important question, or information on this, that it is contraindicated in children. So this is contraindicated in children. Why is the surgery contraindicated in children? Needs a mention here, very, very important and interesting. So this is your, let's understand, if this is the lens, right, with the capsule, we just learned that it is situated in the patellar fossa, right? So this is the anterior hyaloid membrane. Okay. In childhood, when we are small, there is a strong adhesion between the posterior capsule or the lens and the anterior hyaloid membrane. And this strong adhesion is what is called Wegert's ligament. The other name of Wegert's ligament is hyaludocapsular ligament. Hyaludocapsular ligament. Got it? So because there is a strong adhesion, if I am doing ICC, I will remove the whole capsule, it will pull on the Wegert's. Any pull on the Wegert's means it will pull the vitreous. This is something absolutely not needed. Because any pull on the vitreous is a very big risk of retinal detachment. We can cut the vitreous, but we cannot pull the vitreous. So it's a big risk of retinal detachment. Got it? Therefore, this is contraindicated in children. Okay, we are going to learn more about it when we are talking about congenital cataract. Okay, so this was about ICC. What is the next surgery we can do? So have a look here. What we are doing in this slide, what you see here is this is a cryoprobe. Right? So this is your cryo extraction, ICC through cryo extraction. This is your Aruga's forceps. And look at this is a spoon-like instrument. This is what is called wire vectis. Right? So, wire vectis method. Okay. So, next surgery we will talk about is your ECCE with PCIOL. Okay, what is this? This is extracapsular, leaving behind the capsule. So, this is your extracapsular cataract extraction. This is extracapsular cataract extraction. So, what are we doing here if we want to understand? So, this is the posterior capsule and small peripheral amount of anterior capsule. This is left behind. I am only cutting the anterior capsule centrally, removing the lens, cataractus lens, and this whole thing, or you can draw it this way if you want to understand. Some part of the anterior, whole of posterior. This is the anterior capsule, this is the posterior. This whole thing is called capsular bag, right? So this is what is capsular bag, and what we are trying to do, we will be putting the IOL after removing the cataractus lens into the bag. So it is posterior chamber intraocular lens implantation, right? Similarly here also I am going to implant the IOL, I can draw it in this way also. Okay, if you look at the IOL that I am drawing, there are two parts. This is the optics from which the patient will see, and the supporting part is called the haptics. Right? So it is optics and haptics. Question here. IOLs are made up of. So whenever they are asking you this question, IOLs are made up of, we mean non-foldable IOLs. So IOLs are made up of, when they ask you, your answer should be PMMA. IOLs are made up of PMMA stands for polymethyl methacrylate. Okay, polymethyl methacrylate. Please note down. Okay, so now once you know the gist, we have to understand how to do it. Let's see. If this is your dilated pupil, I am sitting here at 12 o'clock, this is 6 o'clock. First thing is, I am this time going to make a little smaller section, not as big as ICC. So it will be between 10 o'clock to 2 o'clock. But of course, it's a full thickness cut at the limbus. After that, what I do? So now once I have given the incision from 10 to 2, full thickness cut. After this, what I do? This is the full thickness cut I have given. I have to cut the anterior capsule central part, and this is what is called anterior capsulotomy. Now, if I am giving this multiple cuts like this type of anterior capsulotomy is what is called can opener technique. We call it can opener technique. Okay, so this is what we are doing. We are going for can opener technique. Once we have done this, what is the next thing? inject water under the margin of this capsule. Water is going to go under the anterior and whole of the posterior and separate the capsule from the lens. How are you separating it? Through water. So we call it hydrodissection. This is the reason we call it hydrodissection. Now, once it is separate, what is my next step? See, I can either do hydrodelineation. So the term itself is self-explanatory. Delineation means now instead of putting the water under the capsule, I am putting inside the substance so that I can remove the separate nucleus from epinucleus and cortex. But you know, practically, I'll just show you the slide to be more clear, don't worry. So practically, we avoid hydrodelineation because it just delays the surgery. We don't need it in majority of the cases. So we just have to do a dissection. After that, with pressure counter pressure, take out the harder part nucleus. After that, clean the bag and put the intraocular lens. After cleaning the bag, we put the intraocular lens. Suture the section again with radial sutures. Okay, so this is your ECC with PC IOL. Okay, before I go and show you the slides, why all the time I'm saying radial sutures? The same I said for ICC. Think yourself. Cornea, limbus, I'm cutting this much, I'm stitching. Am I not changing the corneal curvature? Right? So, my suturing has to, it is seen that if this suturing is equidistant and equal length, means the distance between the two sutures and this length is equal, number one. Number two, the direction of your needle is such, if these are the two ends I have to stitch, direction is such that if you pass an imaginary line, it goes to center of the pupil. This is called radial. If I draw an imaginary line from the direction of my needle, it should pass through center of the pupil. Why radial? Because it is seen that even if suturing definitely is going to lead to post-operative astigmatism. Everybody knows that astigmatism is difference of curvature of the two principal axes. That means difference of power in two principal axes. So you are creating astigmatism here, but if you do a radial suturing, it is minimum post-operative astigmatism. So it goes for minimum post-operative astigmatism. As much possible, I can reduce if I am very good in suturing. That is why radial. But still I am creating one. So what is the next step or the next option if I want no post-op astigmatism? If you don't want any astigmatism, go for small incision cataract surgery. So that would be our third topic, small incision cataract surgery. But before that, okay, so this is what we are doing. We have made an incision here. We are taking out the cataractus lens. This is the intraocular lens, which new lens I am putting here, and that we are done. Okay, see, this is the incision I am giving for ECC, that is extracapsular cataract extraction, right? Okay, so when I say this is the incision, so we first give a partial thickness cut with the blade, and now we are with the corneal scissors we are cutting it through. So in this, around the length of incision is anything around 8 to 10 millimeters. It's very long, right? So this is mainly around 8 to 10 millimeters. Okay, then we talk about what was hydrodissection. You are looking at hydrodissection here, where you are injecting the water between this lens cortex and the capsule, separating the capsule from the lens. Dissection, separating capsule from the lens. Now, if you are injecting the same water which is inside, this time I am separating this epinucleus, look at the arrows, from the nucleus and the cortex. This is hydrodelineation, delineating the different layers of the lens. So I was talking about if I don't want to try to have minimum or no astigmatism at all, then I should opt for, let's write. Then my next option could be SICS, small incision cataract surgery. It stands for small incision cataract surgery. Now when I say small incision, think yourself, instead of cutting long, I am giving just a very small incision, and then I am also not suturing it. So definitely I am not disturbing the corneal curvature, and therefore my post-op astigmatism is almost nil. Right? So this is the basis why I want to do such a hard work of opening very little and trying to remove the cataract from this. Why can't I be comfortable and give a long incision? This is the reason, right? So, small incision cataract surgery, what are the two salient features? The name itself says that the incisions are small. And second, very important, keep in mind, it is a sutureless surgery. Okay? It's a sutureless surgery. This small incision surgery, we can do in two ways. Either we go for, so there are two methods of ways of doing it. Either we can go for a manual technique, or we can go for phacoemulsification. Manual or phacoemulsification. Right? So one by one we will understand. First is manual SICS. So we can learn here itself that manual SICS, the incision length is anything around 5 to 6 mm, or 5 to 5.5 mm is also correct, or 6 is also correct. Okay? So 5 to 6 mm or 5.5 mm. Whereas in phacoemulsification, this is a cube. And what is incision length? 2.75 mm to 3.2. So you can learn it easily as paune 3 se sawa 3. So 2.75 to 3.2 millimeters. Now, first we will understand what is manual. Next we talk about is small incision cataract surgery. So we have understood this very well, that when the incision is small and when we are not putting any sutures, then we are not disturbing the corneal curvature, and hence we don't expect any astigmatism post-operatively. This is the reason why we are doing so much of the hard work, right? Okay. So please give the headings. SICS, this is small incision cataract surgery. So what are the two salient features here? Let's learn like this, that of course the incision is small. And second, very important, this is sutureless surgery. Now, how we manage, we are going to understand one by one. So, first this much. Okay, then we will learn that SICS is of two types. We can do it in two ways. You know? So, what are the two ways of doing it? One is called manual SICS, and the second is your phacoemulsification. So, manual SICS and phacoemulsification. Let's take manual first. What is the length of incision in a manual SICS? So, manual SICS, incision length will be anything around 5.5 to 6 millimeter. Okay, it can be 5 to 5.5, that is also not wrong, or maximum by 6 mm, not more than that. Right? So, where do we give the incision? Now comes this point. So, if this is your dilated pupil, all of you make this? Okay. So, if this is the dilated pupil and this is your 12 o'clock, we make the first incision after dissecting this, raising a flap of conjunctiva and removing the tissues, sclera and Tennant's capsule. We have the bare sclera with us now. And on the bare sclera, I am going to give a incision which is 1 to 0.5 to 2 millimeter behind the limbus. Okay. So, this one is, the distance is from the limb of, I'm so sorry, just 1 minute. One more minute, give me one more minute. Yeah, here we are. So, I said that this is the distance between the limbus and this incision is 1.5 to 2 millimeters. Right. So, when we are giving this incision 1.5 to 2 millimeter behind the limbus, we are giving a partial thickness cut on the sclera. So, do you understand, if suppose this was the limbus, I am giving 1.5 to 2 millimeter behind, partial thickness cut means I will come to some depth. Now, I keep dissecting in that depth, keep dissecting, and when I reach at the limbal area, I puncture and enter the anterior chamber. So, what I am saying is, my first external wound or incision is this one. Once I have given a partial thickness cut, I reach some depth. So, the depth that I reach, now what I am doing is, I am dissecting further till I reach at the limbus, and my second puncture is here where I enter the anterior chamber. So, my internal wound is here, but external is the green arrow, green tick, and the internal wound is the red one. So, what will happen if the pressure rises? Because my internal is here, but my external is Not here, it is behind. So like a flap, it will close. So it's a self-sealing incision because I'm giving these at different planes. So my first plane was first cut, then I dissected further, then I gave the then I was at the third plane, that is when I entered the anterior chamber. So please understand, this is what, because we are starting from the sclera, is called scleral tunnel formation. And this scleral tunnel formation, we will understand, is a triplanar incision. That's why we call it triplanar. I just explained you how. Right? So understood. In ICC, ECC, what were we doing? We were making a full thickness cut. Naturally, if you will cut something full thickness, then you have to stitch it. But if you are giving at different planes, you may manage even without suturing it. It becomes a self-sealing incision. Okay? Right. So once we have done this, of course, the next step would be, as we know, is CCC, right? So I make a round, smooth opening now here. So the next step is a CCC. This is the CCC. Then what next? Again, hydrodissection. And through the water, I am separating the whole lens from the capsule. Then how do you take out the harder part? So because the incision is not totally open, I cannot go by pressure counter pressure as I did in ECC. So what do? I go for visco expression. So press on the posterior lip, and through the viscoelastic, we are trying to take out the harder part, that is the nucleus. So again, it is remove the nucleus. The nucleus is commonly removed by visco expression, that is the viscoelastics. And after that, of course, viscoelastic is very helpful. It is coating the corneal endothelium, forming the anterior chamber, so protecting the corneal endothelium from all this mechanical damage. Now, after this, once you have taken out, we will clean the bag with irrigation aspiration. So we go for IA, irrigation aspiration, and we put the intraocular lens, right? So we go for intraocular lens. What about the last step? Do we need any suturing? No. So that is the best part of it. No sutures required. If you have done it nicely, no sutures required. And this shows that the post-operative astigmatism is negligible or not at all. This is your SIC, yes. Let's have a look. So what do you see here? So we made the primary incision on the sclera. This one is a frown shape incision. This we have drawn here. Okay. So you can make a straight one or you can make a frown. Why do you prefer to make a frown? Because just giving you an idea, it's not that important that you have to know it. So from here to this area is an astigmatic free zone. So whatever incision I will be giving here will not cause astigmatism. But if I am going outside, it causes. So it's more at the PG level thing. So we won't go into detail. But this is the reason a frown is preferred. Because if I make this straight, it will go out here. Got it? So anyways, so what you have seen is that we are making a partial thickness incision out here. If you see here, on the sclera, which is a frown shape. And now what we will do, we are going to dissect further. And when we are going to enter here, we will puncture and enter the anterior chamber. So what happens when I am puncturing and entering the anterior chamber, now I have to dissect it little on the sides here also before I enter. Why? So that my tunnel is broader from the inside than from the outside. It should be of this shape. See here? Something like this. So when this is broader from inside than outside, there won't be any damage to the tissue or any tearing while you're taking out the nucleus. Correct? So maybe from inside it becomes 6 to 7 millimeter, the inner corneal incision, but the outer scleral incision is only 5.5 to 6 millimeter. You don't have to learn all the millimeters, except that outer incision length is good, is important, right? So this was SICS. Now which incision length you have to learn is for phacoemulsification. This was your exam question. So next is your phacoemulsification. So when you say phacoemulsification, we are actually, what are we doing here? Let's understand. So if this is the dilated pupil, okay. So what you are doing here is, you are not giving the incision on the sclera, but our first incision is a partial thickness cut on the limbal towards the corneal sides itself, okay, somewhere here, like this. Once I have given this incision, now I dissect further into the cornea and I am going to puncture the anterior chamber somewhere here. right? So this is what is called clear corneal incision. Maybe this is little far, more closer, but yes, it has to be little bit of dissect and then puncture. So these are actually clear corneal incisions. So these are the clear corneal incision. Once I have given this clear corneal incision, my next step would be, of course, I'm not telling you each and every step. We'll watch a video on phaco. So what we are saying here is that next major step becomes your CCC, correct? So this is your CCC, which is a uniform smooth opening on the anterior capsule. What will be the next step? A very important one is your hydrodissection. I'm injecting water under the capsule to separate the anterior capsule from the posterior. So this is your hydrodissection. Very important, after that, we should always rotate and see that the hydrodissection is complete. Okay, so rotation is a very important part. Now, once you are over with all this, now what do we do? Now, the first question, let me start from there. The first question is, what is the length of the incision? So this length, I think I mentioned it earlier also, पौने 3 से सवा 3, 2.75 to 3.2 millimeters. Now think yourself, how are we able to manage this? We have learned together that the diameter of the lens is 9 to 10 mm. Right? So with the diameter of 9 to 10, the cataractous lens, the nucleus size would be anything around 4 to 4.5. And with that nucleus size, I cannot manage with such a small incision length. How am I able to do that? Because I don't take out the nucleus at all. So in all the previous surgeries that we discussed, we were taking out the nucleus. But here we do not take out the nucleus. Rather, my next step after this, after the rotation and all, I'm going to put a phaco probe inside the capsular bag. Now, what is a phaco probe? Phaco probe is nothing but a hollow titanium needle. This hollow titanium needle imparts ultrasonic energy. From where is that ultrasonic energy coming? So, phaco machine, phaco is nothing but, so phaco stands for lens, right? Emulsification, emulsifying the lens. So, the basis of this machine is it has a piezoelectric crystal and it changes the electrical energy into mechanical energy. And with that mechanical energy, you are breaking the nucleus into bits. Okay, so this is what is happening in phacoemulsification. The electrical energy is converted into mechanical energy and we can break the nucleus into bits. Right, so this is what is phaco. Now comes your next question. The next question they will ask you is, what is the frequency of phaco probe? Please make a Q here. Please make a Q here as well. Frequency of phaco probe, you will answer 40 kilohertz. So it ranges from 40 to 60, but we are going to say 40 kilohertz as a preference. Now, once you have done this, you have broken the nucleus into bits and aspirated, then you will of course clean the bag with irrigation aspiration cannula. That is very simple. And after that, what next? PMMA lens is not going to fit through such a small incision. So our next important point here is we are going to put a foldable IOLs. Right? Now, foldable IOLs, what are they made up of? We will learn foldable IOLs are made up of either silicone, or acrylic. And most commonly we use acrylic. Right? Okay, so this was about your phacoemulsification. We come to the fourth, what is MICS? So what is MICS? It is again phacoemulsification only, but this time, so MICS stands for what? Likho. It is minimal incision cataract surgery. It is minimal incision cataract surgery. Right? So, minimal incision, it is of course the phacoemulsification that we are doing, but this time we are doing it from the incision length of 1.8 mm to 2.4 mm. We have to remember this. So, this is your MICS or minimal incision cataract surgery. And then what is your phaco-knit? Another interesting term is phaco-knit. Now, phaco-knit is a surgery, again a phacoemulsification, the same phacoemulsification surgery. This time is being done by 0.9 millimeter incision length. So we'll just watching the video, we'll see that the silicone sleeve over the probe, even that is removed and then the surgery is done. That is why we are able to manage with such a ridiculously small incision length, right? So after this, just for your knowledge, we put rollable IOLs. They're generally made up of hydrogel. Rollables are made up of hydrogel. So let's have a look. This is just an animated picture to show you. This is of course a phaco probe and how the nucleus is divided into 4 pies. Can you see that? Quadrants 1, 2, 3 and 4. And each is being eaten up. This is the silicone sleeve I was talking about, the white one. Again, this is the irrigation aspiration cannula and this is your side port for manipulation and helping for the surgery, right? You can't do with one hand. You need both the hands to be working. So this is the irrigation aspiration which is going on to aspirate the cortical matter from the bag. This probe is irrigation aspiration probe. This is the same thing. Okay, so before we watch the video, let us also mention this. So sometimes, listen, this is important. Now sometimes the cataract is so mature, it is very difficult to delineate the capsule and do the capsulorhexis. Before so generally we don't prefer to mature the cataract so much these days. We want to operate in a much earlier stage so that our phacoemulsification procedure is easier. We'll use lesser energy and therefore harm the tissues lesser. But suppose the patient has come to you in this stage. So if the patient has come to you in this stage, another option can be stain the capsule. So this is again asked in the exam, which stain are you using to stain the capsule? So please note down all of you. This is trypan blue. We can also use ICG, indocyanine green, but for your level, just know trypan blue. Trypan blue, of course, you will not put directly like this. We first inject air. When you inject air, of course, it will rise up and therefore protect the corneal endothelium. And then you put the dye. Then inject the dye. Wait for some time and of course then wash it away, wash everything, your capsule is stained, now proceed with your surgery and surgical steps. Okay, so this is how is being done in this slide, it is being shown to you here. Okay, so we watched this procedure so that we are absolutely clear. The first step is to create a side port, as you can see, it is being done, creating a side port. 2 side ports are created here. Generally, it should be 3 clock hours away from the main incision. This is the visco being injected, viscoelastic to form the anterior chamber and protect the cornea, right? And now with the capsulotome, we start with the CCC, that is, we make one single nick, raise the flap and start tearing the flap uniformly, right? If you can see that. So sometimes this becomes very, very challenging and you have to stain it. So can you see what we are doing? We are just making one single cut here. Raising the flap and tearing it uniformly. This is what is CCC. It needs a long training process. It's not an easy thing to do. Maybe it's looking very simple. It's not that simple. Yeah, so once the capsule is totally cut and we made the CCC, this is the main incision with the keratome, right? 2.75 to 3.2. I inject visco again and this is now the hydrodissection being done, right? So water under the capsule to separate the capsule from the nucleus. Simultaneously rotating and ensuring that this hydrodissection is complete. This is the phaco probe after aspirating everything above. Now we start trenching. Here we go. This is the first trench that you have created, right? You've parted in a phacoemulsification is being done here. So first step is trenching. What are we are trying to do is we are breaking the nucleus into bits. So this is your phaco probe and you can see the silicone sleeve. So with the side port, I support and try to break it into two halves. Right, so this is broken, the nucleus is broken into 2 halves like this. Okay, Now the side port helps to rotate everything so that again the other part comes in front in my line of phaco probe. We again try to divide this into two. And here we go. And if you realize, water is continuously being poured over the cornea because there can be dryness and visualization will be poor. So we have to keep hydrating that also. See, this way. Again rotate it, again break it into two parts. Right? So if you realize, the 4 quadrants will be created in the nucleus. And one by one, we are simultaneously aspirating as well, all the smaller bits. Emulsifying, eating it up. Yes, here it is broken. So one by one, these pieces are being eaten up. Here you go. Yes. So once we are over with eating up the nucleus, one small piece still left. No, the bigger chunk is being rotated now. And this one seems to be the last one. Yeah. So what is being done? I'll go back here. Let this be clear. Okay, after this, after the phaco is over, now we remove this probe and we replace it with irrigation aspiration cannula. Right? See, we're removing it. Yes, this is the irrigation aspiration cannula. And we try to aspirate all the cortical matter that is sticking. So this is what I have been telling you, clean the bag, clean the bag. This is what is clean the bag. So the slight movement that you see here is like polishing of the posterior capsule so that we don't get any posterior capsular opacification. The more accurate you are, the more least chances of getting an after cataract after. Now we are expanding the capsular bag through visco, and here comes our foldable IOL, which is put inside. One haptic is already in the bag. The IOL is unfolding. The outer haptic is still outside, which, if you can realize, it is in separate blue color. See, now this is being put inside the bag here. Yeah. We now aspirate all the viscoelastic. It's very important to aspirate all the viscoelastic. Why, guys? Otherwise, it will block the trabecular meshwork and cause glaucoma post-operatively. So we have to aspirate all the visco from the capsular bag and anterior chamber. Right? And we have to just irrigating fluid that we are using, you have to fill the whole anterior chamber with that irrigating fluid after aspirating. Right? So we aspirate and simultaneously, of course, we are replacing it with so see, even behind the IOL, all the visco, it is being taken care of that there is no viscoelastic left. It's a tricky procedure. You may actually tear the posterior capsule. You have to be very, very careful. So the centration of the IOL seems fine and everything is clean now. Sorry, everything is clean now. Yeah, so what is this we are doing? Partial hydration to seal the incision. Okay, this is the partial hydration done to seal the incision. So we just saw how we go for phacoemulsification and how we do it. Right? So have you seen the viscoelastic, how we put it to create the anterior chamber, and this is helping in cushioning the corneal endothelium and preventing damage to the tissues. What are these made up of? So let's also talk about that viscoelastics. Here they are mainly made up of hydroxypropyl methyl cellulose. Okay, so note down, this is hydroxypropyl methyl cellulose. And another propyl methyl cellulose, and if you want to go for a more viscous one, this is mainly 1% sodium hyaluronate. Okay, sodium hyaluronate. So these can be the two, you can say, constituents or types of viscoelastics. And if you remember your conjunctiva, in conjunctiva we are going to learn in your dry eye chapter that how the lubricants, the lubricating eye drops are also mainly either methyl cellulose derivatives or they are hyaluronates. Okay, so easy to learn. Also, let's talk about the irrigating fluids. During the surgery, you just watched the video. Very important are the irrigating fluid. Irrigating fluids, what are the fluids I can use as an irrigating fluid in an intraocular surgery? First, of course, is ringer lactate, which we use quite commonly, right? And apart from this ringer lactate, what else I can use? So, sometimes we also put adrenaline in the ringer lactate bottle so that my pupil dilatation is maintained during the intraocular surgery. So, you can actually write here plus minus adrenaline. You want or you don't want. Depends upon the pupil position of the patient. If the pupil is disturbed, constricting, more tending to constrict, it's better to put adrenaline there. Then secondly, we can use, which is the another basal is BSS, that is your, write down, basal salt solution. This is another irrigating fluid. It is isotonic. So I'm going to choose as the best fluid is the one which is more towards the same composition as that of aqueous. So this BSS mainly consists of, easy to learn, all the chlorides of sodium, potassium, magnesium and calcium. Just remember this. Right? And which is the third type? Third type is BSS plus. Many of you must be thinking, why are we learning this? It's an exam question. What is the question? Which is the most ideal irrigating fluid for your intraocular surgery or cataract surgery? And your answer will be BSS plus. BSS plus means all the constituents of BSS with glutathione. On with or may not be with dextrose, but very important is glutathione. Okay, so that was the answer of your question. This is the ideal irrigating fluid. Okay. So once we know about phacoemulsification, we come to the next, and which is the latest surgery that we know. The latest surgery is your laser-assisted, femto-laser-assisted cataract surgery. Okay, so this is the latest in cataract surgery is femto-laser-assisted. So what is femto-laser? Write down, it is femto-laser-assisted cataract surgery. Right. So what is femto-laser? So femto-laser, as you all know, is an ND glass laser. Okay, ND glass laser. And femtoseconds, 10 to the power minus 15. So let's learn here that the pulse duration of this laser is 10 to the power of minus 15 seconds. So this has been your exam question, another Q. And what is the wavelength? Wavelength is around 1054 or 1053, both are correct, nanometers. We are going to learn this in lasers in eye also, but just keep in mind. So either 1054 or 1053 nanometers. Correct? Okay, so what about how it is assisting? So femto laser, how it is assisting? Through lasers we are doing, what are the steps? There are 3 steps which laser can assist in. First is making an incision. Second is doing the capsulotomy, CCC. It is so precise, accurate, perfect round and very, very predictable. If I am doing manually, then it's always a risk to be not very round, or maybe it should not be like not able to make it, or it has extended to the posterior capsule and caused posterior capsule tear. So many risks. So, you know, there's a long training session to do a CCC. We used to do with the practice was with an aluminium foil. If you take that whole cardboard of the round cardboard like thing and you place the aluminum foil over it, and then we try to do it with and then practice it. That's what we have been doing. We did it in our training session also. Okay. So anyway, so that is CCC. And the third that you will know is, the third step it helps in is lens fragmentation. So when you say lens fragmentation, it is, just imagine, you are getting already a nucleus which is broken into bits. You are getting already a capsule which is already pre-cut. Very easy, isn't it? So this is what laser is doing, helping us to make our cataract surgery very easy. So if I have a patient who will, for whom I have to do this, first I will take him to the laser room. In the laser room, I am going to do all these steps. That means I'll make the incision, I go for CCC, I go for lens fragmentation. Now I take the patient to the operation theatre, open his eye, very easily remove the capsule, very easily remove the nucleus because it's already broken. Then with irrigation aspiration, I clean the bag and I put a foldable IOL. And of course, no sutures required. Correct? So this is about your femto laser cataract extraction. Let's have a look. So here what you see is the capsulotomy part done here, right? And this is the lens fragmentation. Actually, this is your examination slide. So please see it very carefully. This was asked that what is the procedure being done. So this is a femto laser assisted cataract extraction. Okay. Here we are comparing that how a capsulotomy here can be irregular, but if it is through the femto, it has to be near perfect round. So once we know about all these surgeries, we should also think about what was the anesthesia we gave before that, because we started with all types of surgeries, we haven't discussed that. So when you talk about the different type of anesthesia, the latest of course is I am putting topical. So one can be just a topical paracaine I put, isn't it? So that is one thing, but you have to see that the patient is very cooperative, he is not moving his eyes. Because what I am getting is your anesthesia but not akinesia. That means the movement is still possible. So we have to keep that in mind. And second, of course, which we most commonly do is your peribulbar injection. Right? So peribulbar injection. When you say peribulbar, let's draw for ourselves before I show you the slide. We all know this, that the muscles are all attached to this, correct? On the sclera, right? Suppose these are the muscles attached. We have to understand that the space, so if this is the muscle attached, this is the muscle attached. The space which is inside is called the cone. This is the intraconal. So this becomes this is your optic disc, optic nerve. And this space all is intraconal because it is inside the muscle cone. And outside is your extraconal, isn't it? So if these are the muscles we are showing, I think this becomes easier like this. Yeah. So any space which is inside is intraconal space and outside that is called extraconal. Right, so extraconal. So peribulbar injection is mainly given in the extraconal space. Just keep in mind. Whereas the third type is your retrobulbar. When you say retrobulbar, this time it is inside the cone. This is intraconal space. So it has a risk of damaging the optic nerve. That is very, very important and we have to keep that in mind. Okay. So when you say peribulbar injection, so that is given with 1 inch needle. Retrobulbar, the needle has to be longer. It is 1.5 inch needle. So that it goes in the intraconal space and this is just a 1 inch needle. Let's see this. Okay, so if you have a look at this slide, can you see this? This is your retrobulbar, which is inside the cone. This is the conal, intraconal space and this is your extraconal space. So peribulbar injections are these. And when it is behind the eyeball here, this is your retrobulbar injection. Intraconal space, we go for retro. So retrobulbar is rarely used. We mainly do for squint surgeries and all because we want to block the ciliary ganglion. We would want to block the oculocardiac reflex. We are going to take that in the squint chapter. But just understand here that commonly we do either peribulbar or we are doing a topical anesthesia. Now, how do you go for a peribulbar injection? We have to keep this in mind. So most commonly you are doing a giving peribulbar anesthesia. And what we do is we are taking the junction of medial 2/3 and lateral 1/3. Okay. So medial 2/3 and lateral 1/3 we put one injection and one is put at the supraorbital notch. So at the notch we put the supraorbital notch, we put this little bit more of the anesthesia there. So this is how we are going to do. So anesthetic that we will put is at the junction of this. So see, the needle is already here to showing you the junction between the medial 2/3 and lateral 1/3. And the second one I am going to put on the supraorbital notch. Done? Okay. So what are we injecting? Keep in mind, write down. So mainly in peribulbar injections or retrobulbar, what do you inject is lidocaine and bupivacaine. Okay. So lidocaine is fast onset with bupivacaine Bupivacaine helps it to be a long-lasting effect. Okay? And lidocaine is a fast onset. And along with that, of course, I can go for mixed hyaluronidase, because hyaluronidase is going to help in spreading the anesthetic through the tissues. So hyaluronidase can also be given with or without adrenaline. We can add this, we can add adrenaline. Right? Okay. So we are giving the same thing in the peribulbar injection, and we are giving the same for the retrobulbar, as I just mentioned to you all. Only difference is retrobulbar is a longer needle, so that it is going to go into the intracorneal space. Rest of the facts are same. Right? Okay. And if just to complete the list, intracameral, that is inside the anterior chamber, we can go for preservative free, because if it is with preservative, it will damage your corneal endothelium. We don't do it that commonly. So I think these three are enough for you at this level. Remember the topical paracaine, remember what is peribulbar and what is retrobulbar injection. Right. So that was about your anesthesia and about the different surgeries. You have operated the cataract and you have put the IOL. Now, what can be the different types of IOL? Let's give the heading types of IOL. Now, when you say types of IOL, we have to discuss that, because make a diagram and understand. Suppose you have operated a cataract and there was a complication and there is a posterior capsular tear. If there is a posterior capsular tear, naturally, I cannot put the lens in the capsular bag. So where are the alternatives of putting the lens if I don't have the capsular support? First is your AC IOL, number one. Okay, keep in mind, first is AC IOL. Second is your iris claw lens. I can claw it in the iris. This is your iris claw lens. And the third best one, why best? Because there the original lens was already there and I want to put it in the posterior chamber itself. How can I do that? For that, what I can do is, because I don't have the posterior capsule, I am putting the lens here and stitching it with the sclera. And these are called scleral fixated lenses. Okay? These are scleral fixated lenses. Right, all of you? Okay, so you can also think this way, that any posterior chamber IOL can be either put in the capsular bag or it can be scleral fixated IOL. So if we write like this, we can say that IOLs, either I am putting into either they are AC IOLs or iris claw lens, right? Or it can be PC IOLs, and PC IOL in the posterior chamber can be put either in the capsular bag or it could be scleral fixated IOLs. And what is that space which is behind the iris in front of the lens? What is that space called? It is called ciliary sulcus. Suppose it is not in the bag, it can be in the ciliary sulcus. So the third type, in the posterior chamber, the IOL can also be situated in the ciliary sulcus. That is called ciliary sulcus PC IOL. Just have this idea. Okay, so let's have a look at these IOLs. What did we learn? That a non-foldable IOL is made up of PMMA, right? The average length commonly is 13.5 or 13 mm. Okay, so it commonly not 13.5, we will say 13 mm. Okay, so it's the optic size which is 5.5, and the total length is generally considered overall diameter. Most commonly is we use 13 millimeter. If it is a child and if I am operating for a congenital cataract, definitely it has to be smaller. Now coming to what were the types of lens I was discussing? Look at the haptic. If the haptic is Z-shaped like this is an AC IOL. Okay? You have to know how to recognize an AC IOL. Can you actually think of, if I am putting an AC IOL, what can be the problems here? Let's think together. We don't have to mug up, we have to understand here. If this is the anterior chamber IOL I have put, first of all answer this. What is this? Iridectomy. I am doing it surgically, so I am calling it iridectomy. Why do I want to do it? Because if there is any pupillary block, and the aqueous flow will be blocked. And if the aqueous flow is blocked, it will lead to glaucoma. We had learned in introduction also. So we are doing an iridectomy for safe side, so that the flow of the aqueous is not disturbed. Okay, first you should know this. But do you understand here that if you have put some IOL in this space, it can damage the corneal endothelium? It can cause glaucoma by creating problem in the angles. It can cause inflammation and uveitis, right? Corneal endothelial damage. Please note down. So if you can just make the diagram and note down something like this, right? Just make this diagram and note down corneal endothelial damage, uveitis, and sometimes even bleeding and leading to hyphema. Right? So when there is hyphema in the anterior chamber, hyphema is blood in the anterior chamber. So this is called UGH syndrome. What is UGH syndrome? It is uveitis, glaucoma, hyphema, mainly caused by anterior chamber IOLs. So that is the main problem why, especially these days, we don't prefer anterior chamber IOL. Come to the iris claw. Iris claw is a plate haptic. Plate haptic means it is continuous with the optic. We call it plate haptic lens. Something like this, as you can see the design here. Can you see the junction? This is the way, this is the place where it will claw on the iris. Like a chimti ki tarah, right? So it will claw. So these iris claw lenses again, they are not free of problems. If they dislodge due to any trauma, they will again cause the same problems which we discussed for AC IOLs. Or it may just cause uveitis, right? So again, not a very, very impressive idea, but yes, these are being done. Rather, these days, it is being also used as a means of refractive correction, right? We'll talk about that in optics. So this is your about iris claw. See, here it is claw. This is the place where the claw is working. Here it is clutching like this, right? Okay, and this is your iridectomy. This one is your iridectomy, right? So this was your iris claw lenses. We come to the next one. So this is your PC IOL. You can see the haptic. This is a posterior chamber IOL. Now one question for you all. What is this hole? And what is the purpose of it? So these are called dialing holes. Okay. When you say dialing holes, you just watched the video when you're putting the IOL. In this case, it was very easily at one time put on the place. But if it is not, I can hinge it with a dialer and rotate it and place it in the capsular bag more properly. That is what is called dialing. It has to be always done in this direction. See, because the direction of the haptic is like this. If I do it anti-clockwise, I'm going to tear everything. So it is always done in a clockwise direction. Right? Okay. So that is your PC. And now look at this one. The haptic has got a loop here. This is what is scleral fixated lens, and this is the place from where I'm going to suture it to the sclera. So these are scleral fixated IOLs. Right? Okay. We come to the next type of IOL. If you have written the list and you're writing along with me, what is the next type of IOL? Let's think over it. All of you pay attention. When you have operated a cataract in a patient, did you realize that the function of accommodation is lost? We discussed accommodation in detail. Right? Nose on use, no attachment to ciliary muscles, so no accommodation. So what to do now? So either I prognosticate the patient and I tell him that, okay, you will be corrected for your far vision, but we cannot take care of your near vision here. You have to use your near glasses. So if the patient is happy enough, okay, no problem, I'll use my near glass, it's okay. But suppose he says, no, I don't want to use any glass. First thing is I'm getting a surgery done in my eye. I wanted some perfect vision. I have been using, why should I use any glass? Do a surgery where I can be like free of glasses, right? In that case, I have an option of using multifocal IOL. So what you're looking at here is a multifocal IOL where we see the focusing at different distances at which you look at. So write down in your list, after AC IOLs and different types of IOLs that you've learned, you can write down multifocal IOLs, which is going to take care of your near vision, intermediate vision, and you don't need a near glass after cataract surgery. Similarly, this is also multifocal IOLs. Any other IOL needs a mention? Suppose the patient has a high astigmatism. We all know astigmatism is the difference of refractive power between two principal axes. So we use cylindrical lens to correct. In our specs also we use cylindrical lens. The same cylindrical correction when you are doing in the intraocular lens, this is what is called toric IOL. Toric contact lens bhi hote and this is toric IOLs. Okay. So toric means I am using a cylindrical correction for astigmatism. If you're not very clear with this, we are going to discuss this in detail in optics also. I've talked in introduction also. So toric IOLs. So how do I know this is a toric IOL? Look at these markings. This will help me to align in whatever particular axis I've decided. I will be able to align the IOL there. So these are toric IOLs. Okay. We then talk about, and few other names of the IOLs that you can also know is heparin coated. It will give you minimum inflammation after surgery. So there are heparin coated IOLs. Okay, another interesting fact. When the lens becomes cataractous, it just absorbs a lot of blue light, and blue light is not disturbing the vision. Now you have operated that cataract. So what happens? This blue light, and actually blue light is damaging to the retina also, right? Shorter wave. So what happens? That after cataract surgery, the patient may really be very, very conscious about and disturbed with this phenomenon. So we can go for blue light absorbing or blocking IOLs. So we can have, so this is a little above, nahi bhi yaad karogi. If you don't want to learn it, it's okay. So they can be blue light blocking IOLs also, so that the blue light is continue to be blocked, right? Yeah. So you should know all this. And then of course, what is aspheric IOL? Where it is actually negating the spherical aberration. We call it, at present just learn this, we will discuss spherical aberration and all in detail. So aspheric IOLs means, just keep in mind, better quality of vision because it negates the spherical aberration. Okay. So better quality of vision because it negates the spherical aberration. That is aspheric IOLs. Right, all of you? So it negates spherical aberration. These are some special types of IOLs that we will keep in mind. Right? Okay. Now once you have discussed this about the IOLs, am I going to put the same power in all the eyes? No. Right? So let's next talk about how do you calculate the power of the IOL. So you know, when the IOLs we started using IOLs, actually there was a time when the same power was used in all the eyes. The same 20 adapters was implanted in every eye. And then you have to do the refractive correction on the specs as per requirement. But now we calculate the power for every patient. So this is first question. What is the method of calculating known as? Answer is biometry. So what is biometry? Write down. It is a method of calculating the power of IOL. Calculating the power of IOL. So method of calculating the power of IOL is biometry. Now how do we do it? So normally we need two readings here. So originally when we used to calculate, the two readings we needed were keratometry reading. What is keratometry? Measuring the curvature of the cornea. So I will take a vertical curvature, the horizontal, and the average of K1 and K2 is taken as a K reading. And second what is I should go for is I need axial length reading. Again, axial length reading, we all know what is axial length, and we also know how do we take it and how do we measure it. We can do it with A scan. Ultrasound, A scan. Are there some other methods also of measuring this? Yes. So as like axial length can be A scan, you have to touch the probe on the cornea. So it becomes a contact method, right? There can be, so axial length, write down further, can be measured by a contact method, which is A scan ultrasound, or it can be measured by a non-contact method. So this non-contact method is what is called optical coherence biometry. Okay, so optical coherence biometry is using laser beams producing interference patterns. Just remember the commonly used word for this instrument is IOL master. So we do it through IOL master. Now IOL master is not only taking the axial length, it's a master, that's why the name master. Axial length measurement, it will also take the keratometry reading. This instrument will take the keratometry reading. Then it is also taking the anterior chamber depth reading and measurements of wide to wide, that means diameter of the cornea, wide to wide measurement. Wide to wide means from one limbus to another limbus, what is the measurement? All these things are possible through your IOL master. Now coming to your keratometry. Keratometry we already know, keratometry can be done by keratometer. Which keratometer? If I talk about the manual which we have been using from years now is your Jewel-Short's keratometer, right? So one is Jewel-Short's keratometer, which is a manual method of doing the keratometry. Or of course I can go for corneal topography, right? Where again we are scanning the surface of the cornea, correct? Or the third could be, you have just learned about the IOL master, where we can see the do the keratometry with this optical coherence biometry, right? So that is a non-contact method. Anyways, whatever it is, after taking these readings, how are we calculating the IOL power? The formula is that SRK formula, right? What is SRK? It's not Shah Rukh Khan, but it's easy to learn as Shah Rukh Khan, of course. But the full form, nobody will ask you. Just know this. It is by the name of the scientist, Sanders, Retzlaff, and Kraft. 3 of them. Anyway, just this was for your knowing it. Otherwise, but this has been asked earlier in your exam. What is SRK formula? So SRK formula for calculating the intraocular power says that power is equal to A minus 2.5 L minus 0.9 K. A stands for? No, it's not axial length. That's the commonest mistake. A is your constant. Okay. L is the axial length and K is the keratometry reading. Done? Okay. Now it was seen that this is best giving the results from 22 mm of axial length to 24.5 mm of the axial length. The results are best with this. But if I have to go further, either it is a longer eye or a shorter eye, this is not a reliable formula. So we will talk about of it generations. There are 4 generations of IOL formula. So generations of formula, just for your knowledge, little bit you should know, not details. We have to be familiar with the names, and then I'm also going to tell you what you really need to learn. One, I told you need to learn about what is original SRK formula. Don't forget that. So this original SRK was the first generation formula, was this. Now, when the longer and shorter eyes were taken care of, that was your second generation formula, and that is called your SRK2. Okay. Now, coming to third generation formula. Now, the third generation, again, you have to know the names only, is SRK by T. You should know about Hoffer's and you should know about Holiday 1. Only names, please. And what is the fourth generation? So, these were all based on effective lens positions. And coming to the fourth generation formulas. Fourth generation formula would be very important because it's asked in your exam. I will first mention this. Haig's L regression formula, or Haig's formula is also enough. Okay, Haig's formula. Then comes your Holiday 2, and Hoffer Q. One more, write down Barrett. Okay, as I said, these only names. Now this fourth generation, please keep in mind, is not depending on the corneal curvature or keratometry parameter. It is mainly based on anterior chamber depth, on the wide to wide measurement, which your IOL master is taking care of. So this fourth generation, we will keep in mind, is based on anterior chamber depth, on the refraction, and on wide to wide measurement. Based on that, the formula is calculated. So what is important to know, even if you don't want to learn this, it is not based on corneal curvature. I think this is most important part. Not based on corneal curvature or keratometry reading. This is very, very important. Now why? Because when you are the patient is undergoing a refractive surgery and the curvature of the cornea is already altered, how you are going to calculate the IOL power? Right? So that will be affected in other formulas. It will not be in fourth generation. Therefore, this was your exam question. Which is the ideal formula for post-LASIK patients? And your answer would be Hagees. Okay. Second question, if it is a shorter eye, what formula you want to use? The best one will become Hofer Q. And for the longer eye, we will answer SRKT is the best one. For longer eye, SRKT is the best one. So this information is something you have to learn, right? Okay. That was about your biometry. Now we are left with, once you've done the surgery, the complications are always a possibility.